And she is now connecting to us.
Or treatment for cancer such as neoadjuvant chemotherapy, where the patient's physical, nutritional, medical, and mental health domains are optimized so as to facilitate the return of the patient to pre-treatment state of health. So, for example, a patient who has prehab gets into a better state of general health, including physical function, and the red bar is where the treatment is, and after that there'll be a decline. However, with rehab, the patient gets back to baseline as compared to patients who did not have prehab but only had rehab, or patients who didn't even have rehab. They are not able to get back to their baseline functional status. When we did the literature review, there were 4 clear-cut domains that we need to intervene in, and that included the medical domain, the physical domain, nutritional domain, as well as the mental health domain. While we did not start with a research project, but a real service, we are also aware that in the many research projects, outcome measures were published, including the 6-minute walk test, the 30-second sit to stand test, and these are the physical domains that outcome measures are collected for. And for the mental health domain, there is the hospital anxiety and depression scale. For quality of life, there is also the EQ5D, and other studies also look at the length of stay as well as the post-operative complications. When you look at the literature review, it was traditional model was largely center-based, involving multiple healthcare professionals, such as the exercise physiologist, the PT, the OT, the doctor, the dietitian, and the mental health professional. As our wait time to surgery was 19 days, we were not sure that if we adopted the traditional model of care, it would have made an impact to the patient. So we redesigned care to make it a one-stop service. So the patient is enrolled on the same day as the surgical clinic visit. There is no need for multiple appointments. Once the patient sees the prehab team on that day, the program can start once the patient goes home. We call it the hospital-associated home-based program. There are potential cost savings because the patient does not need to take time off work to come down to the hospital for the interventions. The patient does not need to travel. There's no need to build extra infrastructure to accommodate for this new service. And there's a follow-up through the whole care continuum by the prehab coordinator who makes phone calls to check on the patient. We started with a pilot in January 2020 involving colorectal cancer patients. We held collaborative meetings with the colorectal surgeons, colorectal specialty nurse and the PAAC, which is the perioperative anesthesia assessment clinic team, to learn about the journey of a newly diagnosed colorectal cancer patients. We wanted to keep, we did not want to disrupt any of the usual workflows, but we wanted to weave our service around the current workflow. So it was we had a small core team. We adopted a level up approach. We performed same day screening as the colorectal clinic visit, and the patient is enrolled on the same day as when he is listed for surgery or referred for neoadjuvant treatment. The PAAC visit is brought forward by the Prehab coordinator. We call it the hospital-associated home-based Prehab model of care. And this is the core team. I have two rehab physicians, Dr. Kwok and Dr. Lee, and Prehab coordinators, Christopher. And our advanced practice nurse, Lina, she is the one who will collaborate with the specialty nurses whenever we start up a new service with a different department. So I'm going to bring you through a pictorial form, what happens to the patient when the patient turns up at the colorectal clinic. So the patient will have been, the diagnosis will have been given to the patient, and all the newly diagnosed patients are screened for frailty by the Prehab coordinator using the physical frailty phenotype, screening for unintentional weight loss, exhaustion, slowness, low activity level, as well as weakness by using the hand dynamometer. The patient will be given a brochure, and the Prehab coordinator explains to the patient what is the cancer Prehab program. Once the patient has consented to be enrolled, the patient undergoes some screening in the physical domain, and the Prehab coordinator collects the outcome measures at the baseline. That means at the pre-intervention time point, performing the 6-minute walk test and the 30-second sit-to-stand test. And these interventions are performed at the back of the surgical clinics. Also, the other outcome measures such as the HADS, EQ5D, these are also collected. Next, the patient will see the rehab physician in the clinic, who will perform an assessment on the 4 domains, including medical, functional, psychosocial, and nutritional domains. An intervention will also be performed in the 4 domains, including medical clearance, exercise prescription. The rehab physician will also do a demonstration to the patient and also get the patient or the caregivers involved in making sure that the patient is able to participate, able to do the written demonstration as well. Dietary advice is given in the form of protein supplementation, a prescription of a general healthy diet, and immunonutrition if the patient consents, as this is an out-of-pocket payment. And so there is also anxiety reduction strategies that's been given to the patient. Once the patient goes home, the program starts. The patient starts to exercise at home and starts to change the diet if necessary. And the Prehab coordinator will make a first phone call at 3 to 7 days after that first clinic visit to check on the patient, to encourage the patient to exercise, as well as for any clarifications that the patient may have. Subsequent calls will be at 2 weeks to 4 weekly till pre-op visit. There's also a number that the patient can call to reach the Prehab coordinator if they have any clarifications. On the day before surgery, the patient turns up again at the Prehab clinic and sees only the Prehab coordinator, who will perform the same these outcome measures, such as the 6-minute walk test, 30-second sit-to-stand test, the time up and go test, and the patient satisfaction survey. The Prehab coordinator will assess and documents compliance by looking at the patient exercise logs, as well as getting the patient to do a written demonstration. If the patient is able to demonstrate the exercises correctly, then we are very assured that the patient had done the exercises in an optimal way. The patient then comes in for surgery, and the Prehab coordinator tracks the patient list and flags up these cases to the rehab physician. A post-op review will be performed while the patient is in hospital. The rehab physician or the APN will then go and see the patient, will cite the patient for further rehab. Usually this is done in the outpatient setting, but for patients who have suffered many serious complications, which is uncommon, then they will be cited as inpatient rehab, or the patient would be continuing the rehab in the home setting, which is most of the time. So for medical optimization, the rehab physician is able to advise the surgical team, including titration of BP and diabetes and so on. And then they will reinforce and adjust the exercise program for the patient while the patient is in inpatient, and give advice on, when they go home, how should they adjust the exercises. There might be some referrals that may be needed, for example, referral to dietitian or PT or inpatient rehab, which is uncommon. And in these circumstances, the prehab coordinator will facilitate this communication to the primary care team. Prior to the patient's discharge from hospital, after the surgery, the prehab coordinator arranges for the prehab clinic at 3 months, the clinic visit at 3 months, and documents secondary outcome measures such as acute hospital length of stay, as well as post-op complications. Next, I'm going to delve into how we expanded into a cancer prehab program, how we expanded into a cancer prehab framework. So we did the lead review and found that these following cancer diagnostic groups had shown benefits in the cancer prehab program. So we listed them down. Okay, because there are other departments that wanted to collaborate with us, for example, urology department, and then after that, hepatobiliary surgery. So we did not want to go and present to the senior management for approval every time. So what we did after the colorectal cancer group was to present a framework whereby all the diagnostic groups that will benefit will be approved for cancer prehab program. So what I presented to the senior management was that there are benefits, including reduction in post-operative complications, and that pre-op period and the adjuvant therapy period is a good opportunity for lifestyle intervention in the patient. For example, exercise, good diet, and cessation of smoking has been shown to reduce cancer recurrence. And Singapore healthcare is generally moving towards a population health approach. So this is really in alignment. And also the prehab can allow the patient to experience a better general well-being and quality of life. Besides, having better physical capacity can lead to improved ability to tolerate adjuvant therapy, reducing the chance of treatment disruption and termination. However, we were cognizant that different diagnostic groups will have different impairments and requirements. For example, urology patients will need maybe some attention to continence as well as sexuality. And then breast cancer patients will need some attention to the upper quadrant range of motion. So these specific requirements and individualization of the work processes will be discussed with the stakeholders prior to implementation in each cancer diagnostic groups. However, what we had with the core workflow, this was preserved, and really it eases us into each new diagnostic cancer group. The patient is screened and enrolled on the same day visit as when they see the surgeons and the oncologists. So it remains the same as the colorectal pilot program. The intervention will be multimodal. And this is the peri-treatment workflow for surgery as well as for chemotherapy and radiotherapy. And it follows what I've already told you about the colorectal pilot program. At the treatments follow-up, patients who are suitable will be encouraged to continue an active lifestyle. Right? It is not very minimal cost. So in 2021, we had the opportunity to launch a cancer prehab app within the Health Buddy app. So the Health Buddy app is what is already in existence. So Changi General Hospital is part of a bigger healthcare cluster called the Sing Health cluster. And they already have an app that allows patients to make appointments, reorder medications, and also for education purposes. So we talked to the cluster corporate communications, and through our CEO, we asked for a cancer prehab exercise diary to be onboarded onto the Health Buddy. So as you can see on this side, when you choose cancer prehab, the list of exercises will come down. We can provide a customized exercise prescription by selecting the exercises that are useful for the patient. And then there are videos that we have recorded, and so the patient will be able to follow along with the videos. So this is the Prehab coordinator who will help the patient to select the exercises. If the patient does not have a Health Buddy app, the coordinator will help to download this on their smartphone. Other features include exercise reminders, as well as the summation of the exercises that the patient has done after the patient has clicked on the app. So this is what one of the exercises look like on the print screen. You can go up to the website. If you Google CGH cancer prehab videos, YouTube videos, you will be able to see these videos, exercise videos. Now, why rehab physicians are taking the lead in CGH? Because cancer is a complex disease, and we would like to provide care across the whole continuum of care. There are many benefits, including blunting the cost of cancer care, less appointments, and all these payments are included into the inpatient bill. It's cost-effective, it is sustainable, we do not need so many healthcare workers involved. And also secondary prevention with lifestyle change reduces recurrences. And we transit care to the community when possible, reducing healthcare costs. And we found that there was no disruption during the pandemic. When the non-essential services were stopped during our lockdown period, outpatient PTOT was stopped. However, because cancer surgery was considered essential, the patients were able to take part in this cancer prehab program even during the pandemic at the comfort of their homes. And also cancer prehab can improve the quality of life. Now, I'd like to present the results from January 2020 to February 2022. So we screened 211 patients and enrolled 120 patients. Majority of the patients are outpatients. Inpatients are those that had, for example, IO. They came in with IO, so they had to be admitted. And then so we start their cancer prehab from the inpatient rehab unit. The average age is 70.4, and majority of the patients are colorectal patients, with also others from hepatobiliary, urological, and upper GI. So the mean prehab duration is 19.3 days. That is the wait time for surgery. So most of our patients are frail and pre-frail, but some non-frail patients also want to take part in the program. Looking at the physical outcome measures, at the end of that 19 days, patients had statistically significant improvement in the 6-minute walk test, 30-second sit-to-stand test, as well as the time up and go test.
always ideal. You have to think about what the patient needs and what is the best based on the condition and the wishes. So make the patient as a party to this thing. Another case, 3 months later, found this 35-year-old lady had a stage 1 radical mastectomy, and of course, these are the common issues that you come across. So we just managed the lymphedema, exercises for the shoulder, gave her a prosthesis, and of course, the sexual counseling to find the more erogenous zones and try to counsel the husband as well, that they can carry on the role of a husband and wife, not think that she is diseased and she doesn't fulfill the desires sexually. Amputation is very simple. We've been dealing with every other day, but you have to look at the METs in the chest, that they should be able to manage the increased energy requirement. Of course, giving silicone prostheses for the ear, eye, these are all in the making. So just to give you an example, okay. Limb salvage has been coming in much more now than the amputations. And of course, you need to give extension prostheses and some kinds of the implants which are also given. Maybe you might require to give a shoe for a race. This was an interesting case. 55-year-old, young gynecologist, wife of our professor in medicine. And she had METs every possible place that you could think of: pelvis, hands, upper limbs, lower extremities, spine, everywhere. And she was in the bed, and she also had paraplegia, sorry. She was bedridden and was in very severe pain. She wanted to go back and start to work. Looking at the METs, looking at the things, looking at the ranges of weight bearing, we counseled, look, you have to be in the bed. In case you go, you will have further problems. It's very unfortunate that you are having this, but at least spend quality time at home or in the bed. But she chose to stay in the hospital to the end of her life, and she died a couple of months later. This was a very high-profile NGO worker, wife of one of the very high government bureaucrat. And she had multiple METs, and the noteworthy were the spine MET at L3, and her pelvis, sacrum, that was also affected. She was given palliative radiotherapy for the METs and bisphosphonates for reducing down the chances of fracture. The main thing that she came was the radicular pain, which was for which she was given spinal bracing and gabapentin and precautions to prevent further problem. The noteworthy thing was pain in the groin, and they labeled it as radicular. The pain in the groin is because of L1 and not because of the L3 which was there. So then we found that she had a fracture of the pubis, and for which we, of course, gave her partial weight bearing and rest for 3 weeks, but the thing didn't end. She was close to 58, 60. Her parents were 90, and they were in another city. She wanted to go and meet, and they were not keeping well. On one hand, we had the rest. On the second hand, we had the social engagement. So the things that we learned from here is, of course, the L3 fracture wouldn't cause a pain in the groin. It was something else, so we have to remember her anatomy well. Treatment was tailored, of course, but the important thing was to give her the season on whether she can go and visit her parents in another place and how she would manage the travel without causing excessive loading on the weak bones because of the METs in the pubic rami. So we allowed her to go, looking at a little bit of risk. The pain that she would have felt sitting at home, not meeting the parents, would have been much more. She didn't know whether she's going to live that long to see her parents, and the parents didn't know how long they would live to see her daughter, which is also having very limited time in the world. So you have to take decisions on that. So this is another case. She had recurrence after 6 years, a very, very important thing to understand. She was a college professor, had 2 children, and she came back 6 years later with brain and the other bone mets. She was, of course, given palliative radiation. And the verdict was, of course, when you have this kind of a thing, 6 months to 2 years max. And we usually have the fear of pain, the disability, and death impending. But how she managed? She knew that it is towards the end, but she prepared for her death. She prepared it till the end, what needs to be done in case she is not there. Most important thing was she kept on teaching. Second thing was she told her husband, you are just about in the 40s, remarry. Told her children, this is the pension I'm going to get, and these are the assets that I have, and they nominated the children for the assets. Whatever loans she had taken, she repaid, and she started spending quality time. Call one relative, stay with me for a week, call another relative, come here for a couple of days. But the important thing was she lived a very peaceful life and absolutely no pain. Why pain comes? That is one thing we'll talk about. But the last day, she had made dinner for her husband, and then she felt, I'm feeling very weak, and her mother was there. She said, can I put my head on your lap? And she died. Absolutely peaceful, without pain, even though she had so many issues. The lesson that we learn from here is live the life fully. There's no reason to panic. Of course, everybody has to die, and prepare for the ultimate. And it's always good to know what you are suffering from and how long you have to know, because knowing reduces down the pain and fear. That is the most important thing. And we had a very big debate on to tell or not to tell the relatives and the patient what they are suffering from. And the verdict was, life is unpredictable, but it's always better to tell. That would have helped the patient prepare just like this lady. So carrying the burden, we all have grudges against somebody. This fellow didn't do this for me. I have this fellow said this thing to me. We have the guilt. I suffered because of this. That is why I have got this deadly disease. We have the desires, we have bucket lists, and then we have to think, what after me? So if we lessen out our burdens, improve the quality of life, pardon those people who are pardonable so that we don't carry that load on our head, and spend the quality time with our loved ones, but the most importantly, carry on doing some useful activity in case you are engaged into work, carry on doing the work activity. But at the same time, when you go and meet somebody, don't talk about how much time did the doctor say you are left with. Don't talk about the illness. Talk about the normal things. That is what the patients need, because they want to get away. They want a distraction. So that distraction has to be given to the patients. That's how it is. The end-of-life care document has been prepared by AIMS. I would suggest that you go through this. Of course, it is partly related to PMR, but giving a dignified death to the people. Then one more thing comes. When somebody is in the ICU, somebody is breathing his last, and you tend to prolong life by giving ventilation. What are we doing by giving the ventilation to a person who has nothing, no quality left, and there is nothing, no cognition left, or it is going to be painful? If the person has to die today, let the person die today, rather than linger on after 10 days and think when to pull the plug out. So that is a very, very big decision. You have to counsel the patient's relatives. They can sign a DNR right in the beginning. You can introduce it to the patient. So that is a very important thing. So in the end, I'll just like to say that every patient from cancer can be helped by PMR. In the literature, it says more than 50% patients have problems with ambulation. More than 80% benefit with rehab. But we still have a long way to go. Thank you very much.
Thank you so much, sir. As ever, it was a very wonderful presentation by sharing your life experiences and the out-of-the-box approach in the PMR perspective in managing the cancer patients. Any questions from the audience, please? Yes, sir. Dr. Ravi.
Mike for Dr. Ravi.
Thank you. Nice talk. There is a recent publication from Spain that looks at the impact of exercise on chemotherapy-related neuropathic pain. Do you have your patients exercise? And if you do, what do you have them do?
You better say whether or not we prescribe exercise during the chemotherapy phase?
They do prescribe.
Yes, they do.
So what do you use if you use it? And what experience have
the
you
thing is, the exercises are important, like with a very close association with the oncologist. They say in case you are given chemotherapy, the first 3 to 5 days are the ones when the WBCs don't go low. But you can continue to work, do normal activities and exercise, and even after, the benefit of exercise during or after chemo is not contraindicated. The only thing is going into the dirty areas which will reduce down, which will increase the chances of infection, or coming onto a group where other people are there, those should be reduced so that the cross-infection from the others when the WBC counts are down are taken care of.
Thank you.
In any case, exercises do help the patient develop better resistance and fighting capacity.
Thank you, sir. Thank you so much.
Thank you very much.
So now we move on to the next speaker, Dr. Jae Young Jeon, Professor of Rehabilitation from Korea, who will be talking on rehabilitation in advanced cancer. Sir. So you are not audible. You may, Dr. John, you are not audible here.
Can we please check from our end, is there an issue with the AV guys of not getting voice from the professor?
Hello, we are working on it. Try to connect.
Is it from our end or it's from his end? Where the problem is, that it's from his end or your end?
Can we call the next speaker as we settle this issue? Organizers, please.
So can you hear us? Can you hear us, sir? Can you hear us, sir? So we are trying to connect to Dr. Gion, sir. Let the technical issues get rectified. Shall we invite the next speaker, Dr. A.K. Mukherjee, sir, to deliver his talk? A.K. Mukherjee, sir, from ARA Healthcare Private Limited, Haryana, Chairman of Vision, for his talk on PMR 2050.
Good morning, everybody. The chair and the co-chair are honorable. And ladies and gentlemen, it's a privilege that I'm got it from the organizers, and I'm grateful to that. And I see the audience, the many younger generations, so I'm absolutely thrilled that the future is brighter for India. My job is to actually, presentation was initially thought that 2050, but as for the Niti Aayog paper, I thought it will be relevant to make it 2030, the future program. And what is going to happen to India? Since the new government is going to come in the May 2024, and it is better that they are searching for the material. And I thought that IAPMR is an important national specialized body. The input from this will be relevant to this. And initially I thought that to make a future presentation for future, predicting the future for by 2030 India, it is necessary to understand that globally and regionally and then locally, since I have been the Director General of Health Services Government of India and also the advisor to the WHO. I'm also involved with the WHO's United Nations and the United Nations program. It will be relevant to make a white paper from this conference and present it. And I wrote to this organization for this particular purpose. So I'll actually skip a large chunk of my presentation and only focus in India because of the shortage of time. In 21st century, we are living extraordinary time. Globalizations, growing economy, demographic change, and epidemiological variation and development of the technology. That is basically happening, which our earlier people in our family, they did not get it. Can you today the people are healthier, they're living longer, and more literate and better educated with a higher income. Our ancestors never assigned more privileges than what we enjoy today. What is happening? Okay, up, this is up. Wait a minute. I'll actually skip all those international one and show it only to the Indian side. Because I thought I'll give a detailed descriptions of the global scene today, but that is because of shortage of time, I'm not going to do that. India in the future, let us talk about India now. India in the future, the population, as you see, that India will be the largest number of population in the world, and beginning with China. And the PMR conference practiced for centuries, and I'll skip that. And you see the fertility, though, in fact, has been markedly reduced, but the rate of growth will be much higher. And most of the Indians by 2046 will be 77.1%, 77.1 years actually old. The large section of the population of India will be old. And dependency ratio That means the 0 to 14 and 65 plus, 96% of the population at the moment, if you see, is about 47%. That means 96% of the population will be supported by the 14% population. And the living in cities, a very large number, the most of the 40s, almost 50%, 47.6% by 2046. That obviously shows what kind of the problems you're going to face. Of course, the GDP is growing and the largest in the whole world, 6.6% the predicted yesterday. And we are the fastest growing GDP one. The PMR, since I have been for a long time, I've been in the field absolutely almost more than 40 years, and introduced in 1960s, and I was privileged to be the founder member of this IAPMR. And then you see the way the growth has taken place in the IPMR is much slower than as compared to the other specialty. Fortunately, some of the good people from this profession has in fact increased, has made a major contribution. That's why the undergraduate curriculum, the training, and today the specialty recognized. There is a study that this specialty was recognized by 96.1%. And today morning I was actually talking that somebody that they're saying, yesterday we had a good program, and that is the way to sensitize the new generation. Now, in the total care delivery system, which we all know, based on the principles of the international systems of the care, the total care delivery system has got immediate and the long term. In immediate emergency medical support and the trauma care, everywhere the rehab person will be needed. And the long-term rehabilitation program and follow-up in the community. I'm very happy to hear that the approaches and the cancer program, both the two speakers have spoken so well. And there has to be, we have a system of the primary healthcare system designed by the WHO long back. And we have a district hospital, we have a community health center, we have a primary health center, we have a sub-center, we have village level. Everywhere the PMR unit can be established, the time has come now to ask for it. And also with the voluntary agencies, you have to collaborate. The National PMS Center, fortunately I have been the trustee and the founder member of the Indian Spine Injury Center, which is a volunteer center, and which was almost similar like a national primary center, a national spine injury center. But there is a call, needs to be a call for the national PMS center. And as you have seen how exactly to be collaborated at the district level, every district should have a letter on of the center. And at the end, there is a need for a white paper by this professional body to give it to the NITI Aayog. That was my actually dream. That's why I prepared the whole document. But unfortunately, I cannot present it. And include the national policies, include the national program, and programs like a PPP model. The PPP model is very vital because the private industries actually carry forward the 75% load of this nation. And the special budget has to be asked for it. And information technology, there is a boom, and that should be used. And connect to the international organizations. Since I worked in the WHO and the UNA, it is vital for you to be in touch with this particular organization. And I hope your profession, your association makes it important, basically, one. Well, I wanted to predict actually 2030 what could happen, but we cannot predict the future, but we certainly can invent it. And all of us should take an oath that we should do that for the future. So that totally different picture by 2030 of the Indian Association of Physical Medicine Rehabilitation make it for the nation. Thank you.
Thank you so much, sir, for providing the roadmap for the growth of PMR and sharing your vision for PMR in 2050. Thank you so much, sir. Any queries? No, sir. Thank you. Thank you so much, sir. We'll now try to connect to the previous speaker from Korea, Dr. Jae Yong Jeon, Professor of Rehabilitation from Korea. Yes, I think we'll play with the, yes, we can go ahead.
Chairman,
Thank
for
you.
your kind introduction. Good morning, ladies and gentlemen. I'm Jae Yong Jeon from Asan Medical Center, Seoul, Korea. I'm very honored to participate in this wonderful session. Today, I'm going to talk about the rehabilitation in the advanced cancer patients. I have nothing to disclose financially. There are various kinds of cancer, and each cancer patient may experience the different impairment according to the stage of cancer journey. Of course, in the advanced cancer stage, more functional problems may happen, and rehabilitation to reduce functional loss is necessary. There are two kinds of cancer rehabilitation approach. One is approach according to the specific cancer diagnosis, and the other approach is problem-based approach. Regardless of cancer care. Among these problems, advanced cancer patients usually suffer from several kinds of problems such as lymphedema, pain, and weakness and gait dysfunction. And those problems need a specialized cancer rehabilitation program. Progression of cancer can make a bone metastasis and the invasion to the nervous system, such as brain and spinal cord and peripheral nervous system, and lead to functional problem. Common problem in advanced cancer patients are cancer-related pain and instability in bone metastasis and deconditioning and motor deficit. Recently, our department published a review article on the rehabilitation of advanced cancer, and I would like to introduce the content of that article today. Patients with advanced cancer face a high symptom burden from the functional deficit due to cancer and cancer-related treatment. They often experience rapid loss of functions as well. As noted by Andrea Scheber of the Mayo Clinic, there are several barriers in the cancer rehabilitation. The relationship between the oncologist and rehabilitation doctor has not been established well in many hospitals. And rehabilitation has not been integrated into cancer care. Oncologist is not familiar with the program of rehabilitation. So I will introduce the process to overcome those barriers in my hospital. The first issue is bone metastasis. I will show one representative case. The 42-year-old woman was referred to due to the weakness of both lower extremity. She already had a history of breast cancer and bone metastasis in the spinal column. In the bone scan, multiple metastatic bone lesion was observed, especially in the cervical and thoracic and lumbar region. In the T10 level, epidural mass compresses spinal cord. In the case of cold compression, early diagnosis and initiation of treatment are very important. And according to the neurological and functional deficit, an appropriate rehabilitation program should be proceeded. we use spinal instability neoplastic score scenes to guide grade spinal instability based on the location of metastasis, mechanical pain, and some characters. According to the score, we classify the patient with stable, indeterminate, or unstable group. A treatment plan is made based on the instability score. Of course, a combined rehabilitation program will be different according to the instability status. MRI is good for evaluating mass extent, and CT is good for evaluating bone stability. Therefore, sometimes useful information about the bone instability can be obtained from chest CT or abdomen CT. Bone metastasis is the major cause of cancer-related functional loss and a very important factor to be considered during the cancer rehabilitation program. In the bone metastasis management, NOMS approach including neurologic, oncologic, mechanical, and systemic approach is well known. But I think rehabilitation should be integrated in this approach. So our group suggests non-PRS approach, adding rehabilitation and pain management based on the NOMS approach. For the comprehensive bone metastasis management, we also use multidisciplinary approach system. Medical and radiologic oncologists suggest the oncology treatment plan, and orthopedic surgeon and neurosurgeon review the mechanical aspect and surgical treatment option, and rehabilitation doctor make a comprehensive plan considering mechanical, neurologic, and functional deficit. Before the cold compression occurs, education about the symptom of cold compression is important. And possible exercise should be recommended to the patient. So we made a pamphlet. This video are for educational purpose for our patient. The patient can get information about the precaution and process of bone metastasis. This kind of information is very important. The content of epidural tumor invasion is evaluated using the ESCC scale. Score 2 or is spinal cord compression with a visible CSF, and score 3 is spinal cord compression without visible CSF. Both the SINS and the ESCC score is important score to identify the spinal metastasis patient. A guideline was created so that medical staff from various departments participating in the treatment of patients with bone metastasis can treat patients according to the standard guideline. Based on the epidural spinal cord compression classification scale, myelopathy, and mechanical instability, and treatment recommendation were made for treatment such as radiotherapy and surgery. To identify predictor of occurrence of severity of neurologic symptoms in patients with spinal metastasis who still had no neurologic symptom, we analyzed the data of our clinic. We retrospectively examined patients with spinal metastasis who visited the Department of Rehabilitation Medicine between 2017 and 2021 using the patient's patient's MRI and the clinical data. We investigate whether epidural spinal cord compression, ESCC scale, and spinal instability neoplastic score since, and the pain character were related to the occurrence and the severity of neurologic symptom within 1 year. Of the 70 patients, 40 patients showed neurologic symptom and 30 patients did not. Multivariable analysis showed that ESCC23 and the SINS and the radiating pain were associated with a neurologic complication. Notably, neurologic symptoms progressed rapidly in patients with high ESCC. This retrospective study provides useful insight in predicting patient functional prognosis and determining management using radiology and clinical data. During the rehabilitation, there are concerns about side effects when resistance exercise is performed on patients with spinal metastasis without neurological lesion. According to this study, the isometric exercise of the paravertebral muscle was able to improve the quality of life of the patient with unstable vertebral bone metastasis without any special complication. After the neurologic symptom developed, a rehabilitation program for the spinal cord injury can be adapted. In patients with spinal cord injury caused by metastatic cord compression, a functional deterioration can be minimized by applying an individual rehabilitation program. The data presented in this paper suggested that the group that received the rehabilitation treatment had a higher survival rate than the group that did not, even though walking was difficult after metastatic cord compression. Asan Medical Center is implementing individualized rehabilitation treatment for patients according to functional need and symptom after diagnosis of bone metastasis. In the field of oncology, patient performance status is classified through ECOG, and it is often possible to recover a dependent ECOG grade 3 patient to an independent ECOG 2 or 1 through appropriate rehabilitation treatment. In many cases, chemotherapy cannot be performed without this improved performance. Rehabilitation treatment can contribute to the improvement of the patient's quality of life and survival period. The next issue is cancer-related pain. I will introduce one case and range of motion exercise. Recently, we reviewed clinical case of patient with metastatic brachial plexopathy. Clinical course at the point of 1 year and 2 year, including pain, range of motion, of shoulder and lymphedema, and muscle power were evaluated. At a year later and 2 years later, many patients had maintained or improved state for pain, muscle strength, and lymphedema through adequate rehabilitation management. To summarize my presentation, I would like to emphasize 3 things. Functional impairment of advanced cancer patients can be managed with a rehabilitation program and improve the quality of life of the patient and their family. The physiatry should be more integrated into comprehensive cancer care team for better outcome. The physiatrist is relevant to this approach. And I would like to emphasize again the importance of multidisciplinary approach in the care of patients with advanced cancer patients. This is the end of my speech. Thank you for listening to my presentation. Thank you. Thank you, Chairman, for your kind.
Both the international speakers are available via emails for your question and answers.
Yeah, the speaker is available online, I believe. And any questions? Yes, Dr. Biswas.
No, sir. We have circulated the email of the speakers in our group, sir, so that the queries shall be answered by them via email. Yes,
Evening.
yes.
Okay. Thank you so much. Over email, the questions can be asked over email. So now it gives me immense privilege to invite our eminent speaker, the next eminent speaker, Professor Dr. R.K. Srivastava, who is a retired Director General of Health Services from the Ministry of Health and Family Welfare, Government of India. And presently, I believe he is also occupied with the disability-related research under the division under the ICMR. And he will be talking to us on digital health and AI in PMR practice, present and future. Sir.
Thank you, Chair. Thank you very much. Delegates, ladies and gentlemen. At the age of 75, talking about digital health AI is not right. But talking before persons like you who are young, who are very much conversant with the subject, who are using it in their day-to-day life, it becomes relevant. So I will talk little bit to you about the transformation which the healthcare is going on at present by using digital health, artificial intelligence, generative AI, and machine learning in healthcare in general, and physical medicine and rehabilitation in particular. So with that background, I would like to give you a little bit information about me, that how I have entered into this spectra. I started post-retirement my work in digital health and AI in primary healthcare. So I can vouch that I have got about 12 years of working experience in primary healthcare by applying various type of point of care devices, digital health solutions, and more so during the COVID period when the domiciliary care and the telemedicine came into existence. So with that background, I hope that I will be talking little bit sensible things, and I wish that you can attend to it. Now my talk will be divided into 2 areas. First is, where are we today as far as the health system is concerned? And the second area is, what is its relevance to PMR? So I start with the health system. Health system has undergone a journey of about 8 years starting from the time of National Health Policy from 2016 and coming down to 2024, in which 23 has seen a sudden tsunami of entry of generative AI in form of ChatGPT and the 6th version which has come in the day-to-day practice. I think everybody who is below 50 must be using some or other form of these type of solution in their day-to-day life. If not that, then in the non-health sector they must be using Uber and Ola. We are all best on these type of things. We started somewhere in 2016 when the National Health Policy permitted entry of digital health, AI and ML. Then the first national health stack was created in 2018, and Government of India in 2019 launched the Health and Wellness Center, which has got provision for experimenting by integrating digital health within its system and as a novel approach so that the gap of the human resource can be taken care of. Then in 2020 they created National Digital Health Mission, and that time telemedicine was allowed by Medical Council of India, and at that time because COVID was at the peak, so government was compelled to initiate domiciliary care. Domiciliary care means e-consultation, e-pharmacy and all those things which are taking care of confinement to the home as well as extension of the services through the technology. Then the Ayushman Bharat Health Mission was started in 2011 on the basis of all these learning which has been documented by Niti Aayog, Health Ministry and the NDHM. 3 digital registries have been created, one for the patient, the consumer, with the ABHA, a unique number. Another is for the provider, the doctor, nurses, which is there in the NHA. And third is for the facilities, that is hospitals, both public and private. There was a lot of discussion about the intrusion of the private player who have got a cloud at USA or some EU countries and who will have access to our data, exploit our data, sell it, and there had been reports about ICMR other places. So in 2023, after a lot of debate, deliberations and so many things, that the Digital Personal Data Protection Act was passed. So all these are the hallmark. After all these things happened, then there came the tsunami of various type of changes which were taking place, including the generative AI. Now the present standing of the health system is like this, that all young, middle age, even elderly, their brain is wired to use digital solutions. So that's why I define it BR-AI in. Your brain has got artificial intelligence inside it. By the way of information entry into the system. And I can say it because we use at least about 10 solutions every day which are developed with the help of AI. Our public health system has got a program and they are using AI-based solutions and digital health. Look at the primary health centers, community health center, you will find that e-Sanjeevani platform is available. Telemedicine consultations are going on. Specialist consultation are also going on. E-pharmacy is taking place. EHR and the data are being generated. It is a type of Internet of Medical Things which has been created by the government, developed by the government system and integrated into the public health system. It has got flaws. I don't say it is perfect, but online you can register yourself, you can get a consultation time, and if you want a specialist consultation, you can book a number and get it. Then the PMJY was created, which faced a lot of problem as far as the fraudulent bills are concerned. So they created a partial automation with the help of AI into the system so that fraud detection become very easy online. If you put up a false bill or a bill which is not appropriate, it goes into the another bucket and thereafter investigation starts. And lastly, because every hospital, public or private, become a fiduciary as far as the DPDP is concerned, and fiduciary has got a responsibility what data to share and what data not to share. And if they have to share certain data, then they have to justify that it is being used for the larger benefit of patients and largely for the research and development purposes. So all these actions which are available at present is giving you a good jumping pad so that we can have a fast moving digital health integration system. Now the present status in the private sector, if you look at, private sector use three things. Number one, automation. Number two, application of the machine learning for the repetitive task. Task of giving appointment, task of billing, task of taking care of discharge, task of taking care of making the report available to the doctors, e-radiology, all these things were taken up by the public-private health system quick and fast. And they have developed in some hospitals which are, say, for example, Kokilaben Hospital in Mumbai, they have developed E2E solution, end-to-end solution of certain type of problems which are emergency related, emergency transport related, related to the triage, related to the various type of post-discharge systems. So they have developed end-to-end solution and integrated it within their overall hospital setup. So ultimately leading to various type of Internet of medical technologies which are in use. Now, for example, I give you some example. Niva Bupa has created online insurance system. Remote ICU in 26 states and union territory were put up in place by a command center based in Bengal, which is being run by a pulmonologist, and they are taking care of shortage of the incentivist over there. So these are the things which are available. Various type of point of care devices which has been made available in a small box in the primary health. This is closing time? So 3 more minutes. Okay. So I stop here. I will go down to the PMR. Just one slide I will take up for generative AI. Now generative AI is what is the basis for the ChatGPT. It uses a foundation model. On that various type of model which do reasoning, solution providing, and during last 2023, it has developed so fast that now it is self-evolving the solutions. The database which is there, they are creating multi-model solutions and it is self-evolving. So this is the future for every public health person to know. Now the business value of AI is, from 2023, it is 20.65 billion, and it is going to be 187.95 billion in 2030s. Now, where are the AI-enabled services utilized in PMR? Now, AI-enabled PMR services in the rural primary health care and the secondary care in a hub-spoke model is a genuine possibility. A PMR specialist who is conversant with it can very well use it. The second is AI-enabled city-based digital networking for providing access to the unmanned health facilities. There are a good number of facilities in the cities which are not finding a doctors, or doctors are absent, or some type of provider or paramedic is spent. So you can develop a plug-in type of model for those who are finding these problems off and on. Now third is the expand use of AI-enabled training modules. There are large number of training modules which are AI-enabled, and if I remember, I have talked to one doctor, he said that on your website you have put up certain type of solutions, certain e-lectures. During last 1 year, there are 58 e-lectures. There were 12,200 viewer of these e-lectures in a year. So there is a good application of these type of services. Now assistive products are coming in a great way. And these are, you like it or not, there are 20 assistive products which are high cost, costing round about equivalent to a SUV. We are imported. And once they are imported, they had to be made in India. So link and develop it, and ICMR is doing a lot of work for that. Now institutional type of rehabilitation model, don't ring it up. Institutional rehabilitation model like pulmonary rehabilitation has been tested and documented in Safdarjung Hospital during the COVID time. So is the cardiac rehabilitation. They will also come in way. And then there are some type of center, make in India things which are being developed. Like Hukuma's exoskeletal system for stroke rehabilitation is being developed by a center of excellence in collaboration with AIMS India, AIMS Delhi, IIT Delhi, and hand, elbow, and shoulder has already been Indianized, and it is costing very, very less, at least around 100 of the cost. So there are all possibilities. Now in solutions like cost-cutting solution like solar wheelchair, they are also possible. And UGPG training, digitally enabled UGPG training 24/7 available through a link in their room is also a possibility. The low-hanging fruit before us is telemedicine PMR service in primary healthcare, telemedicine PMR services in the district hospital, tele-education-based faculty shortage solution, innovation, make in India and startup, and assistive technology. And that is where we are working at present with IITs, NISH, Vellore, Safdarjung, IAPMR Mumbai, and Jaipur Foot, and they are the ongoing activity of ICMR in the research sector, and that is all. Thank you very much. Sorry, I have exceeded 2 minutes.
So that was a wonderful thing, and it's very commendable, sir. You are still active and thinking of AI at, you said, at the age of 75. So we had some learning points there. Is there any question for Srivastav, sir?
I know there will be nothing. Thank you.
Thank you. Thank you, sir.
Thank you, sir. I request the chairpersons to give remarks as we are ending the first session. I request Dr. I request all the three speakers of first session, Dr. Using sir, Dr. Mukherjee sir, and Dr. Srivastava sir, to come to the stage. I request Dr. Tirunavukarasu sir to come to the stage to honor the chairpersons and faculties of session number 1. next session, I request Dr. Tirunavukarasu sir, Dr. Jayakumar sir, and our organizing Kumarasamy sir to come to the stage. Thank you, sir. I request Professor Dr. C. Ramesh, Professor and HOD of PMR and Sports Medicine, Chettinad Academy of Research Education, Kelambakam, former Director and Professor of PMR, Madras Medical College, Government Institute of Rehabilitation Medicine, Chennai. Sir has presented papers at National IAPMR conferences and Physiatrist Meet and Rehabilitation Council of India programs. And sir has been the examiner for Tamil Nadu, Dr. MGR Medical University, SRM Deemed University and other Kerala universities and Andhra and Karnataka universities. And sir has served as executive member of IAPMR and hold the past vice president and treasurer of TNAPMR and has conducted post-polio, surgical camps and disability evaluation programs. And sir is a member in disability board in evaluating physically handicapped persons in director of medical education. And I request you, sir, to come to the dais to deliver the keynote address.
It's indeed a great pleasure to be inviting our professor, who is my teacher, Professor Ramesh, to this wonderful program being conducted at IAPMRCON 2024 in the Coimbatore conference. And it's a delight. We recently had an academic program with him and our postgraduates. The way the teaching, the delivery of his topics and discussions will be enormous, and we'll be delighted to listen to you, sir. To you, sir, Dr. Ramesh.
Good morning, one and all. Respected chairperson, learned professors, delegates, ladies and gentlemen. Thank you so much for kind introduction. Thank you for the organizing members of IAPMRCON asking me to present keynote address and also permit me to topic of my journey in PMR. It is with great pleasure and honor that I stand before you this August gathering to deliver keynote address on the eve of 52nd Annual Conference of Indian Association of Physical Medicine and Rehabilitation, hosted in the vibrant city of Coimbatore, often referred to as Manchester of South India by the Tamil Nadu chapter of IAPMR. To begin with, I wish to salute this great man, Dr. Howard A. Rusk, who is the father of rehab medicine, and another great man, Dr. Frank H. Cruzen, who only coined the word physiatry, both pioneers making significant contribution in the field of PMR. Turning our attention to Tamil Nadu, the state boasts a very rich history in the field, notably with Dr. Mary Varghese, a luminary who secured a fellowship at Institute of Physical Medicine and Rehabilitation, New York, under Dr. A. Howard Rusk. Her return to India in 1962 marked the establishment of first Department of Physical Medicine and Rehabilitation at the Christian Medical College, Vellore. Dr. Mary Varghese's remarkable contribution earned her prestigious Padma Shri from the Government of India in 1972. The Department of PMR was established in the year 1960 at Madras Medical College, attached to Department of Orthopedic Surgery, Government General Hospital. Later in the year 1972, independent department PMR was started at Madras Medical College with Professor I.S. Shanmugam and Professor K. Janardhanam, who were the pioneer in field of physical medicine and rehabilitation, trained and secured D.Physmed degree from London, and later in the year 1975, the PMR department was shifted to KK Nagar, Chennai, as Government Institute of Rehabilitation Medicine. They played a pivotal role in shaping the landscape of PMR in this region. Under the leadership of stalwart like Professor I.S. Shanmugam and Professor K. Janadhanam, the department flourished, and both leaders served as the presidents of our esteemed IAPMR. My journey in PMR began in 1985 as a diploma candidate under the tutelage of Professor I.S. Shanmugam, affectionately known as Professor ISS. I subsequently joined GARM Kekanagar MMC, Chennai as a tutor in physical medicine rehabilitation in the year 1992, where I had the privilege of witnessing the nurturing of PMR concept by Professor K. Janadhanam. Reflecting on my footsteps, born in 1961, a small village in South Tamil Nadu from Kanyakumari to the capital Chennai of Chennai, I found opportunity myself to head the premier government shop rehabilitation medicine until 2019. The words of Professor Howard A. Rusk resonate strongly. Disability is not the end. It is now new beginning. Rehabilitation helps individuals discover their strength and capabilities. Two legendary from GARM, Professor I.S. Shanmugam and Professor K. Janadhanam conducted their ward rounds with this philosophy in mind, laying a solid foundation for my career. I express my deepest respect and gratitude to them for their invaluable academic guidance during my formative years. Participating in PMR conference in Pune and Calcutta provided me opportunity to present the paper fostering academic growth. The first paper I presented in Pune Medical College, Armed Force Medical College, organized by our stalwart Professor Lieutenant Colonel S.K. Jain. And our IAPMR president is our own Professor ISS. My paper is Medico-Psycho-Socio-Occasional Rehabilitation of a Destitute Amputee. I completed DNB PMR in 2001, the exam held at Safdarjung Hospital, New Delhi. I take this opportunity to thank all my examiners and our former directors and senior physiatrists who helped me in my professional career. In the realm of opportunities, I actively participated in poliomyelitis camp and also involved in special clinic like amputee clinic, brace clinic, cerebral palsy clinic, and disability evaluation camp, offering assessment and providing support, and collaborated with the Rotary Club to provide vocational rehabilitation of disabled. These I had an opportunity to attend a polio-free camp organized by Impact India Foundation during my 1984 when I was doing house surgery in Stanley Medical College. The coordinator will be Dr. Professor I.S. Shanmugam. This I was taking rounds in a spinal cord injury with interdisciplinary and multidisciplinary rounds with my medical and paramedical colleagues. I was involved in guiding fabrication of low-cost orthoses like flow reaction orthoses in cerebral palsy patient. My area of interest at that time, the rehabilitation of a difficult amputees like a triple amputee and double amputees. Then my thesis also, outcome of rehabilitation of bilateral amputee. Then it came, I published in my home journal, that is Stanley Medical College Journal. My interest in pain and spasticity management led to the initiation of interventional procedure guiding postgraduate research project. In the year 2005, I saw my involvement in rehabilitating survivors of tsunami while serving leader at PMR at Kanyakumari Medical College Hospital. I worked as a professor of physical medicine rehabilitation at the Institute of Research and Rehabilitation of Hand at Stanley Medical College. In the year 2006 to 2010, I developed a keen interest in managing sequelae and hand injuries rehabilitation, especially brachial plexus injury rehabilitation. On a broader scale, I organize an International Day of Differently Abled Person every year on December 3rd, since from 2010 to 2019 at Government of Rehabilitation Medicine, fostering awareness and inclusivity. This I conducted a wheelchair donation of a tricycle and we are honoring a Director of Medical Education and Dean, Madras Medical College. We are conducting wheelchair race. We are honoring our own Professor Stalwart, Professor S. Romer. He was the first candidate finished physical medicine rehabilitation in Madras Medical College. I am honoring. I am honoring our Principal Health Secretary, Dr. J. Radhakrishnan, IAS. Chennai floods in 2015 presented a significant challenge, disrupting services of GARM Kekanagar. However, with the collaborative efforts, we overcame the adversity, restoring services and glory with the help of Americas, a US-based company. Subsequently, the institute became upgraded with the high-tech equipment like Gait Lab. This is Cospi Medica, Italy, BTS, Gait Lab, and Ultrasound, and EMG, and other sophisticated rehab equipments, and enabled the postgraduates involving in academic activities and better rehab services for the disabled person. Professional challenge was not spared, particularly the unique hurdle faced by our specialty in Chennai. The 3-year diploma course initiated in 1975 at Madras Medical College with affiliation to Madras University was converted into 2-year diploma course affiliated to Tamil Nadu Dr. MGR Medical University to make uniformity in MCA regulation since from 1990. The Medical Council of India advocating starting MD PMR PG course strictly since from first decade of this century. In 2014, through intensive campaign with my colleagues, Dr. P. Tirunavukarasu, later then the president of IAPMR, successfully started the first batch of MD PMR course affiliated Tamil Nadu, Dr. MGR Medical University, breaking the long-standing barrier. This is one of the milestones in history of PMR in Tamil Nadu. I got CME accreditation. That chairman is academic committee, our stalwart professor using, and our past president, Dr. George Joseph, and our own good friend, big man, Dr. B. Ramachandran. I had the opportunity to work in the disability sector, member as a selection committee, director of medical education for a disability evaluation of locomotor, member regional medical court, Rajiv Gandhi Government General Hospital, member working group health and medical education 5-year plan 2012 to 2017, Department of Health and Family Welfare, Government of Tamil Nadu, member working group on empowerment of persons with disabilities, State Commissionerate for Welfare of the Differently Abled, implementing PWD Act 1995 and 2016 for the welfare of the differently abled person. I had an opportunity to participate in a panel discussion in IAPMR Conference 2018, New Delhi, for disability evaluation for the special category of orthopedically disabled candidate through NEET exam. Recognition followed the Best Teacher Award, Dr. MGR Medical University, acknowledgement rendering rehabilitation differently abled people conducting free medical service in locomotor a differently abled person by Indian Medical Center, and State Best Doctor Award from our Honorable Chief Minister of Tamil Nadu, Selvi Madam J. Jayalalitha, in the year 2013. I attained the superannuation from government service in the year 2019, May from GARM and Madras Medical College. I got the opportunity to blessed by our own mentor, Professor K. Janardhanam. Presently, I am heading the Department of Physical Medicine and Rehabilitation of Sports Medicine at Chettinad Hospital and Research Institute, Kelambakam, since from August 2019. So this is a Codomotion gait lab and the gait lab and cardiopulmonary exercise test for assessing the fitness, and you are doing rehabilitation of athletes. This is our indoor sports. I also involved in various research activities published in papers, both national and international. These are all the few papers. I've been involving IAPMR conference since from 1985 to 2022. I got an opportunity to become president of Tamil Nadu Association of PMR. Tenure period is 2007 and 2009, and I hold the post of executive member 2012 to 2014 and 2016 to 2018, and former chairman board of studies, Dr. MGR Medical University, now at present member MD/MS clinical course, Chettinad Academy of Research Education, Chettinad Research Institution, Kelambakam. As we navigate the present day challenges to our specialty, it is evident that physical medicine and rehabilitation faces several obstacles impacting delivery of comprehensive care. From shortage of trained professionals to limited accessibility, awareness, and integration to healthcare system, our field grapples with multifaceted challenges. The shortage of trained professionals poses a great critical concern, limiting our capacity to meet the growing demand for rehabilitation service. Accessibility remains a challenge, particularly in rural areas where facilities are scarce. Despite the invaluable role of PMR, there persists a lack of awareness among both the general population and the medical fraternity. Integration into mainstream healthcare system remains a hurdle, potentially leading to fragmented care and suboptimal outcomes. Technological and infrastructures gap, financial barriers, burden of chronic disease and aging population, and the impact of global health emergencies further compound the challenge faced by the PMR specialist. The recent COVID-19 pandemic underscored the strain on healthcare system, diverting resources from rehab services. In response to this challenge, we turn to technology as a beacon of hope and innovation in the field of PMR. Dear junior colleagues, we need your daring courage, we need your enthusiasm, we need your energy, we need your imagination, a quality of mind and quality of heart, a willingness to follow your passion, regardless whether they lead to fortune and fame. With passion, keep building the specialty of PMR. It is about hard work, the many individual acts, the choice, large and small, that add up over time, over a lifetime to lasting legacy. It is cumulative. It deepens and expands with each day that you give your best, each day that you give back and contribute to your life of your specialty. We are in the realm of new era. Information is all around and free. Learning has become democratic. The future generation will have opportunity to work with cutting-edge technological intervention like interventional physiatry, regenerative medicine, advanced genetics, personalized medicine, assistive technology, including prosthetic orthotics, robotics, big data, artificial intelligence, virtual medicine, telemedicine, and evidence-based medicine. The integration of these technologies into PMR practice not only enhances the efficiency of rehabilitation process, but also empowers individuals with disabilities to take an active role in their recovery. As technology continues to advance, the potential for further innovation in PMR remains vast, a promising improved outcomes and increased accessibility to rehabilitation services. One needs to be aware of the fact that human brain and human hand will never be duplicated. We need to continuously challenge our brains and increase our synapses. We need to stay smarter than our phones. We should not forget that empathy and compassion is first and foremost when dealing with our patient. Always keep out patient's needs and capabilities in context when planning or prescribing treatment. In conclusion, to the aspiring physiatrist embarking on the dynamic journey of physical medicine and rehabilitation, I offer these concise yet heartfelt words of guidance to the aspiring physiatrist. Lifelong learning. Embrace continuous learning in the evolving field of PMR. Collaborative bonds. Strengthen and relationship for comprehensive patient-centric care. Empathy and eloquence. Develop empathy communication, a powerful tool in rehabilitation. Champion patient. Advocate tirelessly for optimum patient care and support. Technological integration. Integrate cutting-edge technologies judiciously for improved outcomes. Balanced compassion, navigate and empathy and objectivity for sound clinical decision. Supportive network, build a network for collaboration, mentorship, and unwavering support, well-being prioritize physical and mental well-being for exemplary patient care, diverse path, explore diverse career path within PMR align with your passions, patient-centric practice, let patient aspiration guide intervention with shared decision-making, advocacy and policy, engage in advocacy to influence policies for enhanced rehabilitation service. As you embark on this marathon in the realm of PMR, celebrate the victories, navigate the challenges with resilience, and above all, strive to leave an indelible positive impact on lives entrusted to your care. Before I conclude, I extend heartfelt gratitude to my parents, the architect of my existence, all senior physiatrists who helped during my career, to Tamil Nadu Dr. M.G.R. Medical University and Chettinad Hospital and Research Institute for the opportunities in the academic field, and also the organizers of this conference for granting me to honor the delivery the keynote address. May the symphony of rehabilitation continue to echo with compassion, innovation, and unwavering commitment to the well-being of the humanity. From the greatness that lies within each of you, so don't ever shy away from your endeavor. Don't stop adding to the body of work which will take us to great height. Thank you for your esteemed attention. God bless you.
Thank you. Thank you so much, Professor sir. It's a great journey in PMR in Tamil Nadu, sir. I am your student. I worked with you as your colleague, and also you are my director. And you are a very silent achiever of so many things, and you have done so much of hard work to improve the specialty in Tamil Nadu, so that the PMR specialty is always thankful to you. When you write the history of PMR in Tamil Nadu, we cannot omit your name, or it cannot be written without mentioning your name, sir. Such a kind of achievements you have made. Thank you so much, sir. Thank you.
Thank you, sir. Thank you.
As a appreciation, kindly accept the shield, sir.
So thank you, sir. For next session, we request for next session of IAPMR.
Next important oration, that is one of the important function that our participation is honoring the Bengal oration that we are going to take it up. I invite our Honorable President Dr. Ajay Gupta to come onto the stage, and Dr. Sanjay Pandey, the Dynamic Secretary, to be onto the stage. Dr. Asim Palit, representing the Bengal chapter, to come onto the stage. Every year, IAPMR Oration is being the part of our conferences. One year that will be taken up by the past president, other year that will be taken up by the Bengal Oration, that is under the guidance of the Bengal chapter. And this time, the Bengal chapter oration has been awarded to Dr. S. Sundar, is one of the renowned physiatrists from Tamil Nadu. I will hand out to Dr. Padmarani to both the brief of Dr. Sundar.
Thank you, sir. We request Dr. Sundar, sir, to deliver the IAPMR Bengal oration. Sir, Sir is the director of MIAT Rehab Center, MIAT International Hospitals, Chennai, recipient of Raghavaya Oration and OHSF Mumbai Oration and Dr. CKR Oration, President's National Award for Social Service and Best Doctor in the state of Tamil Nadu, conducted several ergonomic evaluation projects in industry, and Dodici Award for Best Original Paper IAPMR, and several awards in social service and music, author of the first textbook of rehabilitation now in its 4th edition. We request you, sir. I hand over the mic to the President and Secretary of IAPMR to run the oration. Thank you, sir.
Good morning, fellow members and delegates here. This is a very pleasant moment and a very happy moment that we have. We are now in the process of rendering the Bengal oration, and with us for this prestigious lecture we have Dr. Sundar. Though we are almost all of us are familiar with him, and he is a regular part of us and our family in almost all conferences. So I'm very sure there is nobody who doesn't know him. Nonetheless, it is my pleasure to introduce him as having been a postgraduate MD in PMR and one of the leading physiatrists in the country. He did his MBBS from Stanley in 1977 to 1984. He is also a graduate in Indian music, and that we have had the experience many a times. Currently, he is the director of the MIAT Rehab Center, a standalone inpatient facility for step-down neurological and orthopedic rehabilitation. He has been a medical consultant to several companies and is one of the few practicing ergonomists in the country. He has also authored a textbook on rehabilitation medicine, which is now running into its 5th edition. He has founded the Freedom Trust, through which he conducts regular camps since 1997 for the physically disabled and gives away mobility aids free of cost. He has organized over 1,000 camps and provided over 35,000 physically challenged persons in 12 states all over India with mobility aids and artificial limbs. While being connected socially, on the professional side, he has delivered 4 national orations at the Indian Association of Occupational Health, presented several papers for which he has received several awards, including the Dadichi Award, which is the highest award given to the physiatrists by IAPMR. He received the Best Doctor Award from IMA in 2015, and in the state in 2023. In social service, he has been honored with President's Award for the service to the disabled. That's the highest national honor. He is also a state awardee for the Best Doctor, apart from innumerable awards from the community. He is a prolific Carnatic singer and teacher and has many titles in music to his name, including the prestigious Kalai Mamani from the state of Tamil Nadu. It's an honor to have with us Dr. Sundar. Welcome, sir. Please.
Good morning to all of you, and thank you, National President of IAPMR, the committee that selected me for this prestigious oration, the Bengal chapter, and all of you friends for having been part of my journey in physiatry. So when I was called upon to deliver this oration, I thought I'll speak on what I'm doing right now, which is digital technology in rehab. But then when I spoke to a couple of seniors, they advised me, listen, this Bengal oration is sharing of your own experiences in rehab so that it can be inspiring to some of the youngsters who have come into physiatry. So I thought I'll title my talk as The Road Less Traveled. And this is based on a poem by Robert Frost, which says, two roads diverged in a wood, and I took the one less traveled by. And that has made all the difference. So today I will only speak about whatever decisions I took which were not in the beaten path. So this takes me to the quote by Martina Navratilova. She said, disability is a matter of perception. If you can do just one thing well, you are needed by someone. And I have added to that, so is PMR. If you do something well, the community will take notice of what you're doing. And so I thought, apart from the things that I've been doing regularly in the private sector, I'll also share what all things I've done differently. And this would be the contents of my talk. So I entered Stanley, bright-eyed medical student in 1977, and that is my alma mater. I'm happy to share that last Sunday, just three days back, I was awarded the Best Stanleyan Award, which is given to Stanleyans who have shown uncompromising leadership in medicine. And my years at Stanley, this, the seeds of PMR must have been sown then, when during the rounds in neurology, we used to spend 2 hours or so for discussing a case, and at the end of it, the prescription was physiotherapy, multivitamins, and some other tablets. So I asked the neurologist, what is physiotherapy? What is the physiotherapy being given? And he said, they just move the hands and legs and make them walk. Now, in my mind, this was exactly what the patient wanted to do and why he has come to the department anyway. So I wanted to know more about what is being done. In those days, physiotherapy was almost synonymous with rehabilitation. So I visited the department, got interested, and I met a senior of ours, Dr. Jagadishan, who did PMR. He was teaching in plastic surgery. And he told me, you join PMR, and that is where you will get to see a lot of people with disability and see what you can do for them, and so on and so forth. One thing led to the other, and I joined this institution, which Professor Ramesh just mentioned. Our alma mater is the Government Institute of Rehabilitation Medicine. Now, life in GIRM was, as a postgraduate, we did the routine work, but the person on the right you can see is Madasamy, who taught me what is vocational rehabilitation. That's a big story. But essentially, he conveyed to me that vocational rehabilitation is not what we routinely do or prescribe. It is what he wants to practice as a vocation. Now, this is all these are small, incidents which prompted a trigger in me. In fact, this case that I presented won me the national award. In those days it was only IAPMR award. IAPMR award at the international conference, 1991. And that spurred on me to do more research in fitting different types of prostheses to different upper limb amputees. It got me a scholarship, the Lady Tata Memorial Scholarship, and in those days, times were difficult. Even the scholarship amount of 500 rupees per month was a big sum for me. So when we were doing our routine work in the OP, our director came into our room and said, I want to do a camp, a rural camp. I want volunteers. Guess what? None of us volunteered. Who would go to a rural camp where you have to see again more people that are suffering from disability? and so on, and there won't be any work. These are the sort of things. Why we wanted to be in a comfort zone. We did not volunteer. Then he smiled and said, I thought all of you will volunteer. The camp is in Kodaikanal. As you all know, Kodaikanal is a touristy destination. It's a place where people go to enjoy. So we all volunteered. We were all extremely happy because it's all expenses paid travel to Kodai, and we thought the 3-day camp. We thought we'll see patients for 1 day, and the rest 2 days would be sightseeing. To our utter surprise, there were 150 people on the first day, 200 plus on the rest 2 days. The only time we got for sightseeing was about 2 hours on the last day. Now this triggered another series of thoughts that actually people in rural sector do not have access to rehab care, and two, that the disability prevalence is the same across, whether it is a rural or semi-urban or urban. So that made me, there were again series of triggers in between because I went into private practice, but then somewhere around 1997, which was the 50th year of our independence, I founded the Freedom Trust, which is an acronym for the Foundation of Rehabilitation, Education and Empowerment of the Disabled of Madras. As you know, at that time it was Madras, not Chennai. And we have traveled, I have traveled the length and breadth of the country, providing appliances to people with disability. I'm sure all of you are doing the same thing in your respective places. But this was why thousand people, and during these course of these camps, I have seen several of these patients, which I'm sure you also do on a day-to-day basis. But many of these patients were serving me later on as material for my textbook. One thing that has never been a problem is numbers. So though you see all these towns are in Tamil Nadu, we have been as far as, Vidarbha district. We've been to Yavatmal, we've been to Chandrapur, we've been to Gadchiroli, that is in Maharashtra. We've been to interior Madhya Pradesh, and we've done camps. So wherever we go, we have hundreds of people coming in for our camps. So our process is to provide assess by a physiatrist, take the measurements and give it back in another camp, a distribution camp. And during the course, I saw several of the patients having very poor artificial limbs, and that gave birth to what is called Walk India. Walk India is the same thing. The process is the same. We assess amputees and provide them with the artificial limbs. And this also, a lot of the community gave us the trust a van to make these limbs, and we travel from village to village, and the process, as you can see, is well known, and other NGOs are also in this space. In between, there was an interesting thing in 2001, the Gujarat earthquake, and I was one of the doctors who was called by Polaris, a software company. They called me much later, after the earthquake. And then they said, Dr. Sundar, can you do something? I said, yes, I think there may be a lot of survivors from the earthquake who may be disabled. So when I went to Gujarat, there was no rehab facility at that time in Bhuj. So I went to various places in Kutch district, Bhuj, Bhachau, Rapar, Khengarpar, Rapar, all these places we visited and conducted camps, and that led to the birth of the Kutch Comprehensive Rehabilitation Center. So this is just a bird's eye view of the places that I have been, almost all the districts in Tamil Nadu and 12 states in India. Even day before yesterday, we had a camp at Puttur, which is in close to Mangalore. We still have camps coming up in Haridwar and other places. So it's been a wonderful journey in pro bono work, and a very grateful community bestows, the awards and the recognitions, the state award for best doctor, the President's Award for social service, and several others from other institutions. Very coveted one being the Lifetime Achievement Award from my own alma mater, GIRM. Now I rewind back to 1992 when I came out of GIRM. I was totally flummoxed what to do. I was not in any organization. I was looking at a degree, a diploma in physical medicine rehabilitation under my belt, and I decided to go into private practice. I didn't join government service. I didn't join any organization. And imagine me going from doctor to doctor, explaining what physiatry means and what are the type of patients who used to come. Initially, I started with a couple of physiotherapists, and gradually it grew. At the time of my giving away my clinic or selling my clinic, we had about 60 patients every day. But the point I would like to specify is, in 1992, I think some of you may not have even been born. The concept of physiatry was very poor at that time, and I had to, on the right you can see I have given talks in IMA and other organizations. Just to say, this time the topic was need-based rehabilitation, an emerging specialty for a better tomorrow. Now, of course, it is part of the curriculum. A lot of doctors know what it is. But back then, the IMA, nobody knew what physiatrist was. In fact, I used to get referrals for de-addiction, and I had to explain. There's a spelling difference. It's physiatrist and not psychiatrist. So these sort of patients used to come to me. So to expand all my footprints in private practice, I offered pro bono work in a lot of NGOs. That's one way by which I could expand the footprint back then. So Spastic Society of India or Spastic Society Tamil Nadu, Madurai, so many organizations. I used to go once a month, once a week, offer my services free of cost. And also, by then, physiotherapy colleges started coming in. And at one stage, Tamil Nadu had 40 plus physiotherapy colleges. And unlike MBBS, unlike medicine, there is a subject called rehabilitation in the physiotherapy curriculum. It's in the final semester. So when these colleges, they were approaching the final semester, they were wondering, who will take this class in rehabilitation? So I was there available, and at one stage there was a huge demand for me to be a visiting faculty. And I delivered just that part, that subject alone, rehab alone. And in 1996, some of my students came to me and said, Doc, you're taking nice classes and all that, but your lectures are nice, but we don't have any book to refer. So I told them, we've got Rusk, we had Cruz, and those days, those were the textbooks. You can read. Then they looked at it and said, no, sir, we are physiotherapists, we don't understand anything there. It's too big. So sure, I gave my lecture notes. Those days, I cyclo-styled them and gave it to them. And they had finally some lecture notes. In fact, that's the title of my first book, Lecture Notes in Rehabilitation. I printed the first copy, and it got sold. Today it is, of course, in its 4th edition and sells hugely across India. And we all know we are having a textbook, our book of rehabilitation being released today. How much effort has to go into writing that book, you all must have realized. So single-handedly, it had to be done back then. Now, in this journey, so writing the book, something different. Taking PMR itself, a road less traveled in a way. Private practice, certainly road less traveled. So the road less traveled which took me to occupational health, was serendipitous. I was doing medical examination for a few people. That company, Enfield Group, said, why don't you be our medical officer, part-time? So that was my exposure to occupational health. And for a brief period, I thought I'll be just an occupational medical person. And at one stage, I was part-time consultant to 12 companies. But this exposure to occupational health, attending those conferences, I was also president of the IOH for some time, exposed me to another field, which was an application of PMR in occupational health, which was ergonomics, the way the people work. Now that needs biomechanics knowledge. And in fact, yesterday we had a workshop on how ergonomics helps these people. So the worker needs good posture in order to prevent MSDs. We all know that. But companies are now willing to invest in ergonomic consultancy to identify risk, ergonomic risk at site. So this has again taken me to several industries, the steel industry, the Tata Steel, the China Lignite power industry, the cement, Aditya Birla, all these factories I have visited, more than 40 or 50 big industries. And software, of course, I started off with office ergonomics earlier. Now I don't do much of office ergonomics. I'm concentrating on industrial ergonomics. We have quite a few companies in our, who are on our clients list. And now I have joined the standalone rehab center in an international hospital. And what am I doing? So this is also a road less traveled in a way. I won the Dadichi Award 2 years back for my work in digital technology. And so now I'm just moving into digital therapeutics. My hands-on experience, it's early days, so it's not time enough to make any presentations on that. But just a sensitization for all of you, as Dr. Srivastava has already mentioned, the future is digital. And today you can actually prescribe digital technology, which is approved by FDA, and you can, just as you prescribe a paracetamol or you prescribe any drug, you can actually prescribe a software program, which, of course, the concept itself is only since 2015, and the COVID actually brought about this total change in the thinking. And today, this digital technology is now being prescribed by doctors, approved by FDA. But the point is, it needs, there are certain parameters for that. A lot of companies have joined the bandwagon. They jumped into the bandwagon, and there are, it's estimated huge turnovers. Dr. Srivastava has already mentioned that there's a huge potential for digital therapeutics today. There's also a digital therapeutic alliance working in the field. So again, a road less traveled. Prescription digital therapeutics, these are basically software programs but any of your ordinary, anti-obesity, your Fitbit, all these things do not qualify as digital therapeutics. You need to have a specific application, and it has to be approved and also incorporate best quality practices. And there must be papers presented, real world evidence must be available, and there are obviously trials that have to be conducted. And it eschews traditional pharmacotherapeutics as well as products focused on fitness and such. Needless to say, the pandemic has forced us to think differently, and a lot of things have spurred on, artificial intelligence and so on. And I'll share a few of my experiences in digital therapeutics and rehab. One is EMG biofeedback. I have presented this several times. It can be used to either increase the output of muscle by neuroplasticity or reduce the spasticity in certain groups of patients. So here we used it on a patient with focal dystonia, and she was a child with cerebral palsy, and this you can see she's unable to perform extension of the wrist. And over a period we were able to reduce the spasticity, and she was able to perform some of her, we gave her a target of target potential, and from 54, she was able to bring it down to about 27. These by repeated trials with this thing. And here you can see a person who was unable to use his shoulder abductors. We are training him for external rotation. You can see the ball there, and he's doing the movement and trying to strengthen those muscles therapeutically using EMG biofeedback, and he gets back to his job. So digital therapeutics helping a person getting back to his job, vocational rehabilitation. It's the same patient, Perumal. So the case study which I presented earlier also is about how we improved his range of movement and the power also. The muscle power also got improved over a period with the help of, see, this is only, these are all adjuncts. Let's not think that digital therapeutics alone is the thing. It has to be coupled with traditional or conventional therapeutics also. It's not a standalone format. And my experience with virtual reality, people are going to talk about it today and tomorrow. So my experience in rehab is how we use immersive technology in our patients. So we have a child here with cerebral palsy who is doing something, having an oculus over his eyes. So what is he doing? This is what he sees. This is what he sees, and he's performing this activity. And now digital therapeutics are not just software programs, they're also coupled with biosensors, movement sensors, and so on. And motion sensors are available today, which will predict and also which will also improve, and also using neuroplasticity, encourage the movement of the hands and legs. This also works along with the same principle of neuroplasticity. And now we've not started using it for rehab, but we intend to start. But we have started this motion sensors with prescription of exercises. And these are also available as, you can see the laptop in front. The person is raising his hand, and he's looking at the visual display and synchronizing his activity with the therapeutic exercise program. Imagine a situation where the patient cannot come to you, in which case tele-rehab is the format of tele-rehab. You can prescribe the exercises along with this software. AI with therapeutic exercises.
Keep doing.
The therapeutic exercises coupled with AI. Now, I move on to digital biomarkers, and we all know what a biomarker is. It's basically a measure of some biological activity, and these are quantifiable. It can also include behavioral data. So, yesterday we had a demonstration of this. If you notice carefully, did you hear that? There is a signal when the person slumps, and which makes him sit erect. So this has a lot of therapeutic value in ergonomics when we have to monitor the posture of a person real time. You just fix those biosensors, and the EMG biofeedback will encourage, this is also in Australia, for example. A person lost a case because it was found he sued the company saying that the chair was not good, whereas these people were able to prove that the chair was good, but he was not sitting properly using this biofeedback. So there are a lot of applications in this. Recently, we visited a factory where unfortunately, I'm not able to share the video because of privacy reasons. but we captured the entire activity. You saw on the left a video of the person working. And we are able to capture the minimal and the maximal angles through AI. So the AI, all you need to have is something to take the video, and it measures the angles, and we can also program it to calculate the Rula and Reba. Motion sensors, application in ergonomics, mainly for determining angles. We have started using motion sensors for ergonomics. So when the person keeps doing the work, we don't need to actually measure with the goniometer. We have software on our phones. We can measure the angles. So digital biomarkers, digital therapeutics, these are going to be used more and more in the future. So this is again a road less traveled. And they will compensate for some of the shortcomings of the traditional biomarkers and therapeutics, because you don't need a specialized laboratory, you don't need a special imaging, you don't even need to visit the doctors or the therapists concerned. And during the pandemic crisis, these biomarkers and biotherapy, the digital therapeutics have given a big fillip to that industry. It's now a multi-billion-dollar industry. So once again, the road less traveled. And on the right, you can see another poem by Robert Frost, and miles to go before I sleep, and miles to go before I sleep. So I rededicate myself to the cause of PMR. Thank you, all of you. Thank you, PMR, for this opportunity. I also acknowledge some of my fellow physiatrists, Dr. Jimmy Jose from Tiruvalla, Dr. Anand Verma from Hubli, who have all joined me in this journey for helping me in these camps. Abhishek from Bhubaneswar. They've all participated in our camps. So I expect, or I request many of you to join us and join me in this endeavor to reach out to the rural disabled. Thank you once again.
Thank you, sir. Wonderful talk, very eloquent. You not only talked about your journey, in fact, you also talked about your past and the journey, your journey in IAPMR and PMR through your eyes. It's not only the talk, the less traveled. In fact, it is very less traveled, I can say, and you have shown us a way to look forward towards the road to which the PMR should look forward to travel. And regarding the use of artificial intelligence, machine learning, as our previous session was only on that. So really, thank you so much. And I also thank the Bengal chapter, because the whole Oration has started through Bengal chapter. So, and we have among us one of the senior physiatrists from Bengal, Professor Dr. Asim Palit. So I would like to give mic to Dr. Palit to say a few words.
I am myself Dr. A.K. Palit. I am immediate past president of IAPMR West Bengal chapter. Today, I am very proud to see myself in this position because of Bengal chapter Oration, and it is very proud moment for all of us from the Bengal chapter and IAPMR as a whole. I especially thank Dr. Sundar from my deep of my heart and for all the good words and very learning materials.
Now it's time for felicitation. So I would like to request President IAPMR, Dr. Asim Palit. Sundar sir, please come forward. And also I'd like to request one of the senior physiatrists, very senior, in fact senior most, Professor Dr. Manmohan Biswas, to come on the dais. Sir, please come on the dais.
So many congratulations. Many congratulations, Dr. Sundar, for receiving our Bengal prestigious oration. In this occasion, I give again thanks to all the organizers for selected this prestigious award for Dr. Sundar. Thank you.
Thank you so much, sir.
So we come to an end of this oration, and before we end, we can appreciate a good round of applause for the orator. Thank you everyone.
Thank you, sir. Thank you for the wonderful oration. Now we have come to the end of the oration session. And now we are proceeding to one very important session of our IAPMRCON 2024, a remarkable achievement in the history of PMR, the textbook release of our IAPMR. I request Dr. Professor Kshetra Madhav Das, Consultant Physical Medicine and Rehabilitation Specialist, Professor WBMES, Consultant Fortis Hospital, Consultant AMRI, to preside over the stage and to felicitate the IAPMR textbook release function, sir.
Hello. Hello. Swagatam, Shuva Swagatam, Atha Swagatam, Shuva Swagatam, Ananda Mangala Mangalam, Swagatam, Shuva Swagatam. Yes, I welcome you all to an event which is all about joy, which is a truly auspicious event. Yes, I welcome you all to a historical moment, to an auspicious event, because we're going to start the official release, official inauguration of the first ever IAPMR textbook of PMR. Yes, it was a long due, but the road was never taken until and unless a devoted, dedicated, determined, and dynamic soldier of IAPMR, an able and stable warrior of Indian physiatry, Dr. A.K. Joy Singh, took the initiative and took the responsibility on his broad shoulder. And that is the beginning of the story. But as you know, this kind of huge mammoth work cannot be done, cannot be accomplished by a one-man army. So a team was constructed, picked up, and they have done a beautiful job, a tremendous job. A round of applause for them. Kudos to the team, Dr. A.K. Joy Singh and his team, because, you know, this kind of journey is never smooth. Always the road is lumpy, bumpy. The rose petals are not scattered everywhere throughout the stretches. Rather, thorns are there, scattered here and there. But ultimately, they have overcome the issues, and today, we are having the success of getting our own book, the first ever IAPMR textbook of PMR. Now I welcome one by one the present Secretary of IAPMR, Dr. Sanjay Pandey, the present President of IAPMR, Dr. Ajay Gupta, the past President immediate past President of IAPMR, Mr. Padmanabhan Rasu, Dr. Thirunavu Kararsu Padmanabhan, I beg your pardon for mispronouncing his name, sorry, and the Editor-in-Chief, Dr. A.K. Joy Singh. And as I was telling about the journey, as I was telling about the difficult journey, but ultimately the successful journey, and that is the reason we are here, we have assembled here to release the book. So I'll request Professor Ajay Gupta, the President of IAPMR, to speak something about the journey. Professor Ajay Gupta, please. So, beg your pardon. I'll request the Editor-in-Chief, Professor A.K. Joy Singh, to share about that journey.
Sorry. Thank you, Professor Chhatra Madhav Das. My respected teachers, senior physiatrists, all our teachers, learned delegates, and friends. On this historic day, on behalf of the editorial board, let me do a short introduction of the book that is going to be released today. The name of the book is the test IAPMR, our association, IAPMR Test Book of Physical Medicine and Rehabilitation. And the publisher is Salisbury's Medical Publisher. This book is funded by one of the generous pharmaceutical limited, Intas Pharmaceutical Limited. So the journey of the book, this book started, it was conceptualized in the year 2016, and that time academic chairman was Dr. Firoz Khan. I wish sir is around us. And he was well supported by one of our colleagues, Dr. Abhishek Srivastava. Both of them, they initiated the program, and double applause for Dr. Abhishek. He is one person who found out the sponsor for the book. He should be applauded again. He should be appreciated. He's one person. And it was well supported by Dr. Arasu here, Dr. Sanjay, Dr. Ajay here, that in 2016. And it was dormant for about 4 years. When I became the chairperson of the Scientific Society, then I became society chairperson, economic chairman in 2020. So I restarted the journey in October 2020. That is again with so much of initiation activity and activation from our own president, Arasu, and Dr. Sanjay Pandey. Until now, Dr. Sanjay Pandey is after me to publish this book. And the credit should go to him and to Arasu also. So altogether, so we start listing 122 chapters, out of which 112 chapters were taken instantly by our members. But at the end, 79 remains. So we are going to publish 79 chapters today, the book with 79 chapters. And these 79 chapters are authored by 114 authors from India and abroad. So to tell you some of the highlights of the contents of the book, one of the most important, you must know history to know your language, your subject. History is written none other than by Dr. P.V.M. Menon. So that is history again, that we need to know. Then the philosophy, so is written by my own mentor, Professor Yu Singh. That is another great thing. And organization of the PMR is written none other than by Sir R.K. Srivastava, sir. So many things are covered by senior faculties. So we have what do you mean by a rehab team? What are the approaches in rehab? Then the other thing, like we have rehabilitation of the common neurological and musculoskeletal diseases, management of the commonly associated problems like neurogenic bladder, neurogenic bowel, spasticity, hydrotropic ossifications, they are also there. Then two chapters on commonly used processes and orthosis. Then we have covered two emerging fields. One is regenerative medicine and another is interventional pain management in depth. So then we also included, these are from the foreign writers, advancement in computer use in rehabilitation. That comes from abroad. So that is also included. Then we have also included rehabilitation issues of adolescents and women with disabilities. That has been included. Then unique features and additional features, unlike any other standard textbook of PMR, is addition of the rehabilitation surgery. I must thank Sir S. Hariharan, sir. He asked me to do it. I said I am doing it, and that is there. Rehab surgery is included in this textbook, unlike any other textbook. Some of the challenges that the editorial board come across were like many of us were writing a chapter for the first time. And unfortunately, because of the data available, many are cut in a pitch. And we have lots of problem releasing or publishing a book with lots of copyright and plagiarism issues that we come across. Then so we wanted, actually, when we aim 122 chapters, we thought we'll have 2 volumes. So ultimately, we have to decide with 1 volume only, and maximum limit for the pages was 1,000. So we have limited to 79 because of that. But remember, there were 36 chapters with more than 50 pages. We had a difficulty in that, and one of the chapter was having maximum of 110 pages. And we had difficulty in that. So coming to what we do, what are the reviewing processes? We had undergone 4 reviewing processes. First is about the correctness of the English and about the plagiarism by using the tool Grammarly. That was done by my all PG students, 12 PG students, 2 SRs, including me. It became 15. 15 of us, in one month, we completed this correctness and the plagiarism check and grammar check. We did it. After that, it has gone to we have 9 notable associate editors. Each of them, they have reviewed 9 to 10 chapters. I really appreciate every one of you. They do the second reviewing. After that, the comments will go to the author. Then once we receive the comments, then we send again for confirmation from this is the 3rd reviewing process. When everything is ready, when it has gone to the publisher, everything is set, the final reviewing is done by the chief editor, and it was clear at the end, the book is there. So that is the reviewing process. So the cover that you will be seeing, they were putting, actually the producer wanted to put one robotic, because robotic become so advanced these days. I said, we are not to that age. So we made one picture that is drawn by one of my senior resident, Dr. Monica. So she has drawn this diagram and we have put it. So I must, beyond this, there are many who are working tirelessly. One is the publisher. I want to mention one name, Sapna Rastogi. She worked very tirelessly within the shortest possible time, and we were able to do it because that is, credit should go to her also, the Sapna Rastogi from Salisbury's. And I cannot stop without praising again INTAS. Without them, probably it's very difficult to come out to this stage. And our dream is coming true because of them. And I must apologize to some of, my apology to some of the authors. Maybe I was harsh to some of you at some point of time because I was trying to complete the book and published and released today by 2nd of February. I'm so sorry for that. Please bear with me. I tried everything for the cause of the book, not personally. But please don't mind for that. So with that, so with this, I believe that the demand of having a book of our own, then we are going to supply now, the gap is going to be fulfilled, will improve further by getting feedbacks from the authors, from the readers. So maybe it comes very fast. So I am happy that we have been depending on the Western literatures, Western textbooks like Bradom and Delizas, but like they are suitable for in the standard of the Western communities. The standard of living is very high, which is not applicable to our country maybe. So probably first time we have our own textbook, first time we are having our own guidelines written by our own teachers. Probably this will be a dream coming true for all of us. Thank you very much. Thank you very much.
So with the permission of the President, I'll invite Dr. Abhishek Srivastava to come onto the stage, please.
Thank you, Dr. A.K. Joy Singh, for sharing the stories of the journey. And because of that journey, we are here today to test the success. And definitely, surely, we'll go better and better in future. And now I will request Dr. Sanjay Pandey, Secretary, to say a few words.
Thank you, everyone. And as Sir has said everything about the book, so it was a long, late, very late book, though we have released it today. So it's definitely a historical moment, a moment of pride and proud. The journey will started way year back, but finally it's come to an end. And what a happy ending it is, that we are having our own Indian IAPMR textbook of physical medicine and rehabilitation, written by our own teachers, mentors, and everyone contributed. I am not going to name the name again because Joy Sir has already told everything. But I would like to mention the names which nobody knows. The resident doctors of RIMS Imphal. They have worked like anything. They have worked like more than any one of us, or not less than any one of us has worked that. Overnight they have, Joy Sir has shared few pictures with us in the group. I know how they have worked. So really appreciate you guys. And this is Indian book. Whole context is Indian. All the authors are Indian. So what a better way to represent Indian textbook of physical medicine and rehabilitation better than this. So we are looking forward to read it. I myself very eager to just go through it and read it. So I again thank you all, and thanks again, Joy Sir, thanks the INTAS, but again I am thanking them, especially Sivangi, I think here from INTAS, and they have really supported us. And you rest assured, each one of you is getting this book at your doorstep by the hand of these people. Okay, so I am requesting you, we are sending this mail to each and every member of IAPMR, please update your current address as soon as possible. Only after updating your address and contact detail, you are going to get this book. So thanks a lot. Time is less, so just I am thanking and have a joyous moment, enjoyable moment, and just savor this historical moment. Thank you all.
Thank you very much, Dr. Sanjay Pandey, for your brief talk. Now I would request Dr. Ajay Gupta, President IAPMR, to have a few words.
Good afternoon, everyone, again. And this is a very pleasurable moment that I stand here. It was a long journey. It was a very long journey. And I think Dr. Arasu, myself, Dr. Firoz Khan, and Dr. Abhishek Srivastav, I still remember that day when we sat down and we started talking about having a book for the Indian context, by Indian authors, with the Indian practice things in it. From the point of how to write that book, how to fund that book, how to publish that book, many steps were involved beyond just writing the book. And I think as an association, we did accomplish all those steps. And today is, while, as Sanjay was saying, it's a culmination of that effort, but it's the beginning of the continuum that will now happen. And obviously the book will see future editions coming in as a regular activity. So that becomes the activity of IAPMR, and we are proud of it. The important context, as Dr. Joy highlighted, I think the book tries to bring in it the gamut and the wide variety of practice of PMR that is being done in India. So now PMR as a specialty has come of age, and we have all practitioners who are focused and specialized and delivering excellent work in their own areas and their own specializations. And that's where this book brings in the expertise of all the authors in their own area of work. It is also, it may be very prudent now that we dedicate this book to the stalwarts of PMR who brought this specialty to India, and it will be very fair to remember the elders like Dr. Mary Varghese, Dr. M.V. Sant, Dr. S.K. Verma, Dr. B.P. Yadav, Dr. P.B.M. Menon, Dr. S.K. Banerjee, and Dr. S.K. Sarkar, who were the founders of the specialty of rehabilitation in India. And I think we should dedicate this book to all these founders, and that we are blessed with their efforts and their labor that we are enjoying the fruits of today. We would also like to stress upon the fact that Sanjay was trying to tell you. The book will be distributed via the channels of Intas Pharma, and for that we will be using the official registered email addresses of all members in our database of IAPMR, and therefore all members must make a sincere effort to log into the website and update their addresses so that the books can reach to them. Having said this, I have been in this virtuous position of being the president. I got the privy to many chapters, and I stand vouch to what Dr. Joy was saying, that all the chapters written have been written with immense effort, edited with accuracy, and very Indian contextual content is there in all of them. Most chapters will talk about practice in India and not just necessarily of global guidelines, and I think that is what will be the USP of this book, not only for IAPMR and for us, but also as the first book of the Southeast Asian region. And I think that is where we are trying to target this book to, and we will be making efforts to spread it across the areas in this place. And of course, it's a mammoth task to bring the whole team together, to bring so many authors together, and it has taken sleepless nights at the get-up and the way that book has come out in full color. Thank you once again. Thank you, Dr. Joy and his team, and thank you, Dr. Arasu, for having started this work. Thank you all members who have contributed as authors in this book. Thank you once again.
Thank you, Dr. Ajay Gupta. Now, last but not the least, Dr. Thirunavukkarasu Padmanabhan, the immediate past president of IAPMR. I would like to request him to say a few words.
Distinguished delegates and my dear friends, a very good afternoon to one and all here. Many of you will be wondering why I'm standing here and the book is being released here. The history has been revealed previously by none of the other Joy Singh and our Sanjay Pandey and Ajay Gupta. The seeds of the book has been laid down by Dr. Feroz Khan, and at that time the link was missing. One of the three things you require: the concept, the methodology, the funding. And three things were available. There is no connection between them. I made the connection between them. That is why I'm here to take it apart. Because there was funding available, there was a concept available, there was a book publishing capacities available at the IAPMR, and there was the concept that it happened in January 2000 in our Golden Jubilee IAPMR conference, where there was nothing is getting connected to that. So I made a trail mail of about 2 mails to there, connecting all the people with Joy Singh and the funding and all those things. And this regard, why I brought Abhishek is the funding concept was initiated by him and is taken up by the INTAS. INTAS continued and the funding was to be increased to a larger amount, and they are able to do that. And I really thank Mr. Jagrup Singh, who all the way came to my place when I was the president and handed over the check to me for getting the book to be published. So that is a story. So Nandri Marappadu Nandrandru, Nandralladu Andre Marappadu Nandri. That's one of the greatest Tirukural by the Tiruvalluvar. So you have to thank all the people who are behind this scene. Right? I have in this regard, the Feroz Khan, the Abhishek, the great editor, because we are all the people here can coordinate. He is the man behind the scene, and completely taking the issue, the timeline, the minute, the second, the things, mails will come. People know the effort, and he is mentored by his Professor Yu Singh. Yu Singh was giving a great support to him, and all his efforts are being well supported, guided by. We have to really be thankful to Professor Yu Singh sir on this regard, and take this opportunity and be a part of this great event. And one of the book, and just was listening to Dr. Jai, he was telling such a book by any major associations, not there is the first other book from in Asia. So that gives a great happiness to us being a part of the IAPMR here and releasing the book. Thank you for the opportunity. Thank you very much. Thank you.
Thank you very much, Dr. Padmanabhan. Now I would like to call the names of all the advisors, the associate editors and editor-in-chief. Many of them are already on the stage, and I will humbly request to all others to please come to the stage. The advisors, Professor Ajay Gupta is already there, Professor Padmanabhan is also there, and I will humbly request Professor Upinder Pal Singh to please come on to the stage. Dr. Feroz Khan, Editor-in-Chief, Professor A.K. Joy Singh is already there. Now I am calling the names of the associate editors. Dr. Abhishek Srivastava already on the dais. Professor Anil Kumar Gupta. Professor Pankaj Kumar Mondol. Professor Shuman Badhal. Professor Srijit Kalathum Marath, Professor Anupam Gupta, Professor Sanjay Kumar Pandey is already there on the stage. Professor Sri Kumar Venkataraman and Dr. Venugopal Koichil. And the whole team is feeling that everybody has done their job and everybody was totally involved. They have gone beyond their daily routine capability and effort, but one person among them has crossed the miles, went beyond the miles, and always ready to go beyond the miles. That is Dr. Abhishek Srivastava, and the whole team is feeling that Dr. Abhishek Srivastava should be requested to say a few words. I'm requesting Dr. Abhishek Srivastava to come into the mic.
Just a couple of words. It's a very momentous occasion because the work was begun by the previous committee of Dr. Feroz Khan. Today we are missing 3 people here. One, Dr. Feroz Khan from the initial committee, Dr. Jagrup Singh from Intas, who gave us the money with one phone call, and Sonu Singh from Publishers, who helped us significantly complete the book. Thank you very much.
Thank you very much. Now we have reached to the historic moment, and we are going to actually officially inaugurate the first ever IAPMR textbook of PMR, and we are going to unveil it. But wait a minute. It's a historic moment, truly historic moment, and we are launching our textbook, our own textbook. So I think let's make it a little dramatic. Everybody with me, everybody here and in audience, will count down from 10 to 9, and when we'll utter 0 at the together, the book will be unveiled. So let's start. 1, 2, 3, 10, 9, 8, 7, 6, please, wait for me. 5, 4, 3, 2, 1, and 0. So it was a long dream, and we have achieved the dream. And with the achievement of the dream, I, the conductor of this program, is concluding the ceremony with everybody's permission. Thank you all for your wholehearted participation.
I think it is best that we sign at our pages. Okay, have this sign, have this sign. No, just two copies. Sign and take them to IAPMR office for recording. And the others. Will you sign, sir? Do I start signing? Yes. Not there. Okay. The front only? This is here only. Okay. Or we have another page here. We can sign here also. Okay. Dr. Joy? Sign first. Yes. Please give. Okay. Okay, I'll take. We need two books. These two? Yes. Auspicious day. Together is 10. Wow. Together is 10. Yes. There were two books were open. एक आप रखेंगे, वही तो करो, एक आप रखेंगे, ये वाला, एक IAPMR ऑफिस में वो हम अलग से करके वैसे देखेंगे। This is your copy. So you give this to me. This is IAPMR copy I am taking. Okay? And that is your copy. You take that one, which is all signature. Okay. That is the official copy. Official is here. Yes, official copy is here. One copy is yours and like that. Right. Personal copy is
was a wonderful session of the release of our textbook. Now we are having the prize and merit certificates distribution of the caring quiz by Professor Dr. U. Singh, sir.
Thank you very much indeed. It's been such a proud moment for all of us to see the book come into the light of the day with the efforts of so many of us. May I have your attention, please? A little bit of order in the audience. Please. Please. We have been doing one quiz or the other during the conferences also. Last year, we conceived with an idea of having a quiz online after watching a movie because we wanted to create learning, fun. So we've had a very enthusiastic response in the previous quiz, and similarly, we did another quiz where a movie on a person having Duchenne muscular dystrophy and the caregiving that was slated to be, fundamentals of caring. We felt that it was very good learning process for the persons in PMR. So all the postgraduates were invited to watch that movie and then answer a quiz, which was also held online. And I'm very happy that we again had wonderful response. About 68 of the postgraduates, they participated in it. So from Mahatma Gandhi Medical College and Hospital where I work, the Mahatma Gandhi University of Medical Sciences and Technology came forward to sponsor the prizes and the certificates. So here we are going to distribute the prizes and the certificates. May I now request Professor Joy Singh, our chairperson of the academic committee, to give the honor of distribution of the certificates. So Dr. Joy Singh doesn't require any kind of an introduction. So I believe that all the persons top 10 we have gathered here. We have cash prizes for the top 2, first and the second prize. The first prize comprises of rupees 2,000, and the second prize 1,500. So may I call upon Dr. Bharat Pulvarti to kindly come on the stage to receive the prize and the certificate. The second prize goes to Dr. Indrajit Deshmukh. He is not around, but he has requested Dr. Arvind Kumar Sharma from his institution, assistant professor, to receive the prize on his behalf. Since the competition was pretty tough, we had a very good merit, not like the last time. So I felt that even though we had 2 prizes, cash prizes, we should give a certificate of merit to the top 10. I will request Dr. Joe Anthony. He is not here, but Dr. Jayavardhan Kumar from his institution is there to receive the certificate, please. Next certificate of merit goes to Dr. Prasanjit Bhadra from AIMS Bhopal. Dr. Bhadra. I didn't receive a feedback from him whether he's coming or not, so I'm moving on to the next person. Dr. Semi Hangma Maden, please come on the dais. And along with that, another is Dr. Shoibam Jennifer. Both are from AIMS New Delhi. Dr. Shoibam is not coming, so I'll be giving both the certificates of Dr. Semi and Dr. Shoibam Jennifer to Dr. Semi. The next prize is from Dr. Priyanka SU. She is from RIMS Imphal. So very proud moment for Dr. Joy and me to honor. We have a couple of more. Dr. Anshini Gupta, please come on the dais. Dr. Anshini Gupta is from AIMS Rishikesh. The next certificate of merit goes to Dr. Moyangar from RML Hospital, New Delhi. We had Dr. Meghna Khatri from my own institution, and I will give the certificate to her. So that completes the list. A couple of points I would like to say. Dr. R.K. Srivastava was just now talking about AI, and I found that while answering the questions in the quiz, majority of the people, they just use AI copy-pasted on that. I don't say don't use AI, but use your own brain. And I also remember the time when internet came and we all started working, getting the things from the internet and started copying things from them. And then there was a thing about getting the information from the internet. And they said, you get the information, but who puts the information there, that matters. And who is giving the information, that matters. So when you download something from the AI, always remember what is your input in that. So never ever copy paste anybody else. Each patient is different, each doctor is different, the requirement of each patient is different, and what you can give to the patient, that also has to be unique. So please carry on that in education as well. I don't say don't use AI, definitely use, but use it with wisdom. Thank you very much indeed, and thanks to the organizers for giving me this opportunity.
Dear delegates, the chief guest has just arrived and we are about to start the inaugural function. I request all of you in the stall premises to assemble inside the main auditorium. I welcome Dr. K. Narayanaswamy sir, Vice Chancellor, Tamil Nadu MGR Medical University, as the Chief Guest of Honor for our inaugural function of IAPMRCON 2024. Welcome, sir. I request Dr. Narayanaswamy sir, Vice Chancellor, Tamil Nadu Dr. MGR Medical University, to come to the dais to occupy the guest of honor slot. I request our organizing chairman, Dr. Chellakumaraswamy sir, to accompany the chief guest to the dais. I request Dr. Ajay Gupta sir, our National President, Indian Association of Physical Medicine and Rehabilitation, to the stage. Thank you, sir. I request Dr. T.M. Subbarao sir, Principal, PSG Institute of Medical Sciences and Research and PSG Hospitals, Coimbatore, to come to the stage. I request Dr. J.S. Bhuvaneshwaran sir, Director, PSD Super Speciality Hospital, Coimbatore, to come to the stage. I request Dr. Sanjay Pandey, Honorary Secretary, IAPMR, to come to the stage. I request Professor Dr. Tirunavukarasu sir, Director, Government Institute of Rehabilitation Medicine, KK Nagar, Chennai, to come to the stage. I request Professor Dr. T. Jayakumar, Retired Director, Government Institute of Rehabilitation Medicine, KK Nagar, to come to the stage. Now we are starting our inaugural function with our Tamil Thai Valthu. I request all the dignitaries to stand up and we are playing the Tamil Thai Valthu.
நீராறும் கடலொடுத்த நிலமடந்த கெளிலொழுகும் சீராறும் வதனமென திகழ் பரத கண்டமிதில் தெக்கணமும் அதிசிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you. Now we have the Kuthuvilakku lighting ceremony. I request our chief guest, Dr. Narayana Swamy sir. I request Dr. Ajay Gupta sir, Dr. Subbarao sir, and Dr. Bhuvaneshwaran sir, and Sanjay Pandey sir to light the Kuthuvilakku and inaugurate our function. Welcome sir.
जनगणमन अधिनायक जय हे भारत
I request Dr. Chellakumara Swamy sir, Organizing Chairman of 52nd Annual National Conference of PMR, to deliver the welcome address to the gathering.
Yeah, very good afternoon to all our seniors, the respected dignitaries, and my colleagues and juniors who have assembled here for our 52nd Annual National Conference, IAPMRCON 2024 at Coimbatore PSG Institute of Medical Science and Research. In this auspicious occasion, and it's a very important day in our history of Tamil Nadu chapter of Indian Association of Physical Medicine Rehabilitation, that we are organizing this mega event here in Tamil Nadu, and we organizers are very happy and we thank, I welcome Professor Dr. K. Narayanasamy sir, Vice Chancellor, the Tamil Nadu Dr. Medical MGR University, for being the chief guest of this program. And I welcome our National President, Dr. Ajay Gupta, IAPMR, for this wonderful occasion. I welcome Dr. Sanjay Pandey, our Honorary Secretary of IAPMR from AIMS Patna. I welcome Dr. T.M. Subbarao sir, Principal, PSG Institute of Medical Sciences and PSG Hospital, Coimbatore. And I welcome Dr. J.S. Bhuneshwaran sir, Director, PSG Super Specialty Hospital, Coimbatore. And I welcome Professor Dr. Tirunavukarasu sir, Director, GRM, Chennai, and Dr. T. Jayakumar, Retired Director, GRM, KKNR, Chennai. And all our seniors, whoever has come here from different parts of the country, and all my colleagues and juniors in search of wisdom, I welcome you one and all for this occasion. And we have initiated a spark with a new concepts from this conference of IAPMRCON 2024. And in the different names, we have initiated the faculty development program, a unique program. Likewise, we have initiated a PMR sensitization program for students of MBBS and MBBS graduates, and all new way of scientific sessions and scientific programs in 3 different areas. So just to make sure all our delegates get their best knowledge out of this conference. I welcome once more all our dignitaries and all the delegates for this conference. Thank you one and all.
Thank you, Dr. Chella. We now request the President of IAPMR, Dr. Ajay Gupta, to felicitate our Chief Guest and Vice Chancellor, Dr. Tamil Nadu, Dr. MGR Medical University. It is an honor to present a book which was released today, the textbook of physical medicine and rehabilitation, published by the Indian Association of Physical Medicine and Rehabilitation. Thank you, sir. We now request our guest of honor, Dr. J.S. Bhuneshwaran, Medical Director, PSG Super Specialty Hospitals, to address the gathering.
Good afternoon, ladies and gentlemen. Respected senior colleagues and dignitaries on the dais, colleagues and dignitaries of the dais. First of all, I take this opportunity to welcome you all to Coimbatore. In Coimbatore, PSG Healthcare Campus, a campus of very unique nature, which has multiple health institutions and hospitals. I thank Dr. Ramurthy, who is one of the senior physiatrists physical medicine consultant with us for quite a last many years. We are very happy that such a event of this caliber happens in our campus, and I'm sure that you find Coimbatore a very different and a unique place. So especially our president is full of smiles. Smilo smile, we call it in Tamil. So he's been so happy that, very nice of you, sir, you came and told me that you are very happy to host such conference in this campus. And as you know that in PSG we take immense pride in offering a tertiary care, even you can call it as a quaternary care, in which we offer good services with the academic background of the medical college. We are very happy that our current Vice Chancellor is one of our esteemed colleague, a senior gastroenterologist, and we are very happy to see the people from all around the country with various backgrounds, with various experiences have assembled here to share their experiences. So from my personal side and from the management side, we offer our heartiest felicitations as well as heartiest congratulations for this wonderful gathering. Sit, relax, learn, and if you find time, please go around in Coimbatore. Coimbatore is fully surrounded by a lot of yogic places. So you can get enthralled in yoga if you are interested in your free times on the weekend, and enjoy the conference. Thank you very much.
Thank you, sir. I now request the Secretary IAPMR, Dr. Sanjay, to felicitate Dr. Bhuvaneshwaran. Thank you, sir. I now request our guest of honor, Dr. Subba Rao, Principal, PSG IMS&R and PSG Hospitals, to felicitate the gathering.
Respected Vice Chancellor, dignitaries on and off the dais, delegates, invited faculty, and my dear friends, a good afternoon to all of you. At the outset, as one of the co-hosts of this organization, of this program, the 52nd Annual National Conference of the IAPMR, I welcome you all. I distinctly remember, as much as 6 months back, the first conversations we had with Dr. T.S. Chellakumarasamy and his team. And from that moment on, every day he has been thinking about this conference, and you are seeing the fruits of it. I think we should give it up to this, Dr. Chellakumarasamy and Dr. Padma for rising to the occasion. A big round of applause for them, for all the efforts they have taken. Because nothing was clear in the beginning. They had to begin from step by step, get clearances, talk to people, find out the protocol, and work out the space, work out the various, and various programs were carved out. Some were cancelled, some were added, some materials are not available, some had to be substituted. Looking into all of these things, I think they have really put a wonderful program in force, and I therefore appreciate and congratulate the entire organizing team for their efforts. Yesterday, I had been to the workshops which was conducted. They had conducted 2 workshops, one on this campus and the other one at the Royal Care Hospital, and I hear that the reviews are very good about both these workshops. And conferences such as these offer a dynamic platform for learning, collaboration, and personal development. I thank you all for coming from the length and breadth of country, and I wish you all a wonderful learning experience. Thanks for this opportunity.
Thank you, sir. Thank you for your wishes for the conference, and thank you for the support from PSG for the conference. I now request Dr. Jaykumar, former Director, Government Institute of Rehabilitation Medicine, Chennai, to felicitate Dr. Subbarao. I now request Dr. Jaykumar, former Director, Government Institute of Rehabilitation Medicine, to address the gathering.
Good morning to all. Respected VC sir, respected dignitaries in the dais, I feel honored and in great pleasure to be a part of this great conference. As from Tamil Nadu, we used to connect from my PG period. First one we conducted in 2001, then 2014, and again in 2022. This is the fourth one after I took PMR. It's very nice to see all my friends, colleagues, and also PMR is growing in a great way. My request to VC sir is we have to promote PMR in Tamil Nadu in a great way by starting a few more postgraduate institutions like Stanley and Madurai Medical College, because we need hands. And the one thing is we have to expose the MBBS students for PMR in a great way. The PMR, we know that is taken back from as a mandatory course, but we have to bring back the PMR to MBBS students so that they will be exposed. Because PMR again, after this COVID also, it's very important that pulmonary rehabilitation, and also people are becoming aged and developing so many musculoskeletal complications. And rehabilitation is again a very, very important in any person's life. So that now we are growing and we need more hands to develop this course in a great way. So that we need it in a MBBS course as well as in Tamil Nadu. Most of the colleges are now having a PMR department, but we need still more hands. So that we need a lot of postgraduate institutions. Now we are having 5 seats in JIRM and 2 seats in KMC and Annamalai University and CMC Vellore. But we need to produce more postgraduates to develop this specialty so that it will be more helpful to the public in the future. So I request our Vice Chancellor to do the help for us, and I'm thankful to the organization committee and made me to a part of this, and also I thank all my colleagues and friends. Thank you so much.
Thank you, sir. I now request the organizing chairman of this conference, Dr. Chellakumarasamy, to felicitate Dr. Jaykumar. Thank you, sir. I now call upon the Director, Government Institute of Rehabilitation Medicine and former President of IAPMR, Professor Dr. Tirunavukarasu, to address the gathering.
Respected Vice Chancellor of Dr. Tamil Nadu MGR Medical University, Professor K. Narayanaswamy, the Chief Guest of this 52nd Annual IAPMR Conference being held in Coimbatore. Respected my President, Dr. Ajay Gupta, Secretary Dr. Sanjay Pandey, and the faculties and the senior personnel from the administration, from PSG Hospital, Dr. T.M. Subbarao, Dr. J.S. Bhuvaneshwaran, and of course the dynamic organizing team, Dr. Chellakumarasamy and Dr. Padmarani, and all the senior faculty and professors from across the India, and my senior postgraduates and students. Very good afternoon to one and all here. Indeed, a happy moment to be here, standing in front of this August gathering and to be participating in this conference. And after the initial hiccups of where is the location to be, site whether it's Chennai or Coimbatore, despite all the difficulties, I would really thank and appreciate the Tamil Nadu chapter of IAPMR for rising up to the occasion and conducting a mammoth IAPMR National Annual Conference here in Coimbatore. And in this regard, I take immense pleasure in congratulating the organizing chairman, Dr. Kumaraswamy, for taking this initiative to this level. And of course, I have to thank the PSG hospital and the team headed by Dr. Ramamurthy, the professor of the Department of Physical Medicine, for having organized and coordinated with the IAPMR team to conduct this conference here. When I was given an opportunity and I was given the responsibility to invite the chief guest, I would indeed have to tell you with indeed great pleasure, and the moment our director, the vice chancellor, has taken up that responsibility with the grace and happiness to come here despite our delayed response to him, and he is here, and I have to really thank and congratulate for all the way taking his initiative to be here to inaugurate this function. And on the regard of the IAPMR, and I really thank our Vice Chancellor for being participating gracing the occasion, sir. The Vice Chancellor is a great personality here, because I have to tell about two important things about his career. Instead of hepatology and hepatobiliary sciences, exclusive a director post and director, a building exclusively for hepatology, is standing in Rajiv Gandhi Government Rajiv Gandhi Government General Hospital under Madras Medical College is still there, means it is under the efforts of our Dr. Narayan Swamy, and he is the person who is behind exclusively a department and being created for the hepatobiliary sciences, and you really have to appreciate his efforts on that. And is another most important, probably the people being our delegates would have been come across, a great conference has been initiated or been initiated by our Chief Minister, and the mentor and the program or coordinator is none other than our Vice Chancellor. The future of medicine, a big international level conference was recently concluded, and he is the architect of the conference, and a 3-day mega academic fees across the specialties. In that, rehabilitation specialties has given a separate half a day program, over which the number of delegates, will tell you, they'll get astonished. 11,000 delegates have participated in that. It's never been in the history of any of the academic programs such a number of delegates have ever been participated. And about 500 speakers, about 200 speakers from abroad took that initiative, and the great coordination architect exclusively able to under the dynamic leadership of our Professor Narayan Swamy and the Vice Chancellor, and it's a proud moment. He is being participating in our conference, and is very happy to be associated. He is standing in front of you, sir. Coming to the conference, yes, as a mega event has been initiated, and I have to really appreciate the efforts of the local organizing team headed by our organizing chairman, Dr. Chella and Dr. Padurani. 8 workshops. I never, I think, had any history of before that any workshops, number of workshops, 8. The huge learning experience for the students, so that is the initiative, that the thinking that have the knowledge has to be instilled to the students, so that they become a part of the future of the PMR, and that is the initiative they taken. Second, the major theme is PMR 360. That's about that ultimately the workshops that covers that concept. And of course, the faculty development program initiated by our secretary and team has also been taken up. And of course, the introduction of PMR to MBBS students. That's a new initiative. Now been taken up in previous conferences. That is been taken up. So a lot of interesting, important initiatives that implement of the specialty. And really, I think the academic program and all the 3 days program will be definitely delightful to all the delegates. And I wish the conference a grand success, and I wish all the delegates have a wonderful peace. And I thank the organizer of the team for giving me the wonderful opportunity. Thank you for being here.
Thank you, Professor Tirunakarasu. I request Dr. A.J. Rajendran to please come on the stage and felicitate Professor Tirunakarasu. Thank you, sir. I now call upon Dr. Sanjay Kumar Pandey, Secretary, Indian Association of Physical Medicine and Rehabilitation, to deliver the Secretary's address.
Good afternoon and greeting from IAPMR. First of all, I'd like to thanks our chief guest, the Vice Chancellor, Dr. K. Narayanasamy, the Principal, the Director of PSG Hospitals, Coimbatore, our Thiranabu Karasu sir, Director GIRM, and nonetheless, the most important person in our IAPMR, our National Secretary, Dr. Ajay Gupta. But above all, I would like to convey my sincere thanks to entire PSG administration for wholehearted support they have provided to our organizing committee for holding such a wonderful conference. And the most important role played by organizing this conference, the TN chapter president and the organizing chairman, Dr. Chellasamy, and Dr. Ramamurthy sir. You are there in this auditorium, okay sir. So whenever we talk about a conference, I really salute you. Whenever we talk about any conference, holding a conference, and if there is a single faculty in a medical college, they just tell us, no, we cannot hold this. Forget about the national conference. Even midterm CME, they will refuse. But salute to your bravery, your courage, your dedication, in your support. Being a single faculty, you have held a national conference of such a great magnitude. How you did it, you really need to know. Okay. And Dr. Padma Rani, Dr. Rajendran sir, Dr. Uday Singh, all credit goes to you because the 9 pre-conference workshop never heard of in the history of IAPMR. Though we are 52-year-old association, but 9 pre-conference workshop, all totally sold out. Never, I have never heard, and you did it. So great, congratulations sir, and thank you. Dr. Naveen for acting so. Dr. Naveen is here, he is professor from JIPMER, Department of PMR, on the scientific program. So congratulations Dr. Naveen. And theme of this conference is not more than apt, this 360 degree. So as a PMR specialist and in association, the theme is indicating us or directing us to just don't look at in one direction. Like in my experience, though my experience is not a very big one, but a smaller one. So we are mostly focused regarding this musculoskeletal rehabilitation, this neuro rehabilitation. Dr. Chellasamy and team is saying us, no, this 360 degree. The PMR look to need regarding the need of rehabilitation, 360 degree vision. That doesn't mean we need move in circle and circle, obviously, but 360 degree theme, and they have also opened our third eye. So I am not taking much time, but must say the role of an association, because this is our inaugural function of IAPMR. As a secretary, what I feel, the role of association has many things, and every office bearer should make himself or herself accountable to the members of association for the cause of association. So as far as academic activity or academic thought or academic vision of IAPMR is concerned, I can say we are doing pretty good in our journal. Now our journal is being published at regular interval, and we are getting quality articles from our own members, and I appreciate them and I thanks them for sending the articles to our journal. Regarding the textbook, that is the dream of every IAPMR specialist in India, and we are looking for it since 14 or 15 years of my IAPMR existence. And now this day, the TN chapter, in fact Tamil Nadu, the land of Tamil Nadu actually made it possible. Our dream can be realized, and today we just released our textbook. This is the first textbook in the entire SARC country, written by Indian authors, Indian context, and relevant to Indian residents. But nonetheless, it has international significance, quality material, and everything in it. We have started the master class because initially we have this only this IAPMR conference, midterm and annual conference. This is very less as far as academic hunger of our residents are concerned. We have started master class series, and the first series was conducted very successfully at Patna AIMS over a spinal cord injury. And this is going to be a quarterly activity. So be prepared yourself to attend maximum of those classes. Again, we have started this faculty development workshop to help our faculty to develop their personality, their aptitude, their knowledge, their appearance, how they face the interview and everything. And we did it first time here in Coimbatore itself in the PSG campus. Now we are again moving forward towards starting or reviving, I can say, the special interest group. And not one, we are starting 7 SIG. Okay, so the theme 360 degree should really come true. We are starting this autism, this CP, this spinal cord injury, stroke, pain and arthritis, SIG, and very soon I will inform you about it, how we are going ahead with this. Regarding NMC issue, yes, we are facing trouble with this NMC decision. The policy they have taken like this, making this IAPMR rather non-essential list, among the non-essential list of subject. But don't get yourself discouraged, okay, because the NMC is not everything. They are policy makers, they have made a policy. It's a dynamic thing, they are going to change it again. Because the nation and everybody needs rehabilitation as per the guidelines of India, government of India, or be it WHO. But in such institution like PSG, the Vice Chancellor himself is here in our conference. His presence, his graceful presence is showing how much faith he has in this speciality. Similarly, we are getting large number of these vacancies, recruitment, notification everywhere. So don't get afraid by this notification. Have faith in yourself, your ability and everything. Coming to skill enhancement, yes, our association is doing everything by holding such kind of master classes and many things. Now the previous morning session was on artificial intelligence and this machine learning. I must thank to ICMR for sponsoring that session and bringing the stalwart speaker for this session. So yes, we need to incorporate these things under our vision. And also last, the incorporation of entrepreneurship and the corporate culture among PMR specialists. This is the need of the hour. We should not be dependent or looking every time forward for the government job in a medical college. We need to develop ourselves to such a level so that we can create job for many other people. So this is the, you can say, secretarial address from the inaugural desk. So thank you all, and thank you the organizers of this IAPMR conference for inviting me and giving me this opportunity. Thank you. Jai Hind, long live IAPMR.
Thank you, sir. I now request Dr. V. Ramamurthy, Professor of Physical Medicine and Rehabilitation, PSG, IMS&R, to felicitate our National Secretary, Dr. Sanjay Pandey. Thank you, sir. I now call upon Dr. Ajay Gupta, National President, Indian Association of Physical Medicine and Rehabilitation, to deliver the presidential address.
Respected Professor K. Narayanasamy, Vice Chancellor, MGR Medical University, our past President, Dr. Thiruna Vakrasu, Director, GIRM KK Nagar, Professor T. Jayakumar, Retired Director, GIRM, Dr. T.M. Subbarao, Principal, PSG, IMS and Research Center with PSG Hospitals, Dr. J.S. Bhuvneshwaran, Director, PSG Super Speciality Hospital, our colleague Dr. Chelakamar Swami, organizing chairman of this conference, Dr. Padma, the main organizing secretary for the function and the ceremonies, delegates present to attend the conference, our senior and eminent faculty from the specialty of physical medicine rehabilitation. Good afternoon, one, and good afternoon to all. It is an immense pleasure to be here in Coimbatore, and as Dr. Bhuvneshwaran said, I am very happy with the hospitality and I'm certainly enjoying it. It shows in the level of meticulous care that is being taken by the PSG Institute, in the kind of guest house facilities that are provided. So I think you didn't need to say it, it was very evident. On the same front, like Dr. Subbarao said, Dr. Chela Kumar Swamy has been organizing this program for the past 4 months. He has been running day and night. The one man who has made this feasible for all of us is also an executive body member of IAPMR, and I think IAPMR stands in obligation to him to have taken up this arduous task and done it in Tamil Nadu once again. Thank you, Dr. Chela Kumar Swamy. It will be unfair if I do not mention Dr. Ramamurthy, who is the faculty at this institute and who provided all the support and the consent for having it at this institute. And I think he has been long associated with this hospital, which gave him a lot of leeway in organizing this program. Physical medicine rehab, as we see from the theme of this conference, is a 360 specialty. And if we will look at the scientific content that is built into this program, there is not a specialty of medicine that is not touched by rehabilitation, or that does not require medical rehabilitation at some point of care in their patients. Therefore, the question of the need of physical medicine and rehabilitation is settled. The question is not of the need, the question is of our ability to provide. And I think such conference is a very important platform where we try and enhance our abilities. While it is important, and it is very fortunate that we have Professor Narayan Swamy with us here, and we would definitely request him that as the VC of the Medical University of Tamil Nadu, he must encourage more and more postgraduate training programs at the colleges under his university, and not only that, try and inculcate more rehabilitation approach in the UG education as well. As I'm sure you might be aware that the competency-based curriculum of NMC already has about 40 plus PMR competencies which have to be imparted to undergraduates who are closing their MBBS program. So while we have this obligation to provide this care, it is also important that as administrators, somewhere we try and develop the departments which can do this activity for us. At the same time, rehabilitation continues to be the 4th pillar of medicine and is an important element of the national health policy as well. From the times of 1930s, when it was started by Dr. Howard Rusk and Dr. Frank Cruzen, I think we have gone a long way. And from the times of just physical medicine to rehabilitation, to use of artificial intelligence, machine learning, virtual reality, I think the scope of rehabilitation practice is endless. It is for us to imagine as to how we want to dwell upon and how we want to deliver the care to our patients. And again, for this, it is important to understand that a patient of rehab is not a patient for a day or a patient for a month. He is a recipient for years and many a times through his life. So the evolution is not only about the ways of treatment, but the evolution is also there on the treatment being offered to every individual at every individual level. There is I can in no way overemphasize how rehab and a good rehab facility contributes in the society at large in increasing the productivity of the persons, in reducing their dependency, and reducing the need of secondary caregivers to persons who are disabled in one way or the other. Having said that, I think while it is important that centers come up for rehabilitation, it is also important for us as professionals that we constantly upgrade ourselves and we develop our own skills. While strengthening of hospitals and colleges happens, we need to strengthen ourselves to be able to deliver everything that is required at each center. My experience of various centers across the country shows that there would be very few 2 centers in the country which have the same gamut of services. The services have to be individualized and prioritized to the need of the people there and to the need of the institution there. So there is no single cut, copy, paste model of rehab, and therefore a good service provider is required and a good consultation mode is required to deliver those services. Having said that, I think the way I see forward for physical medicine rehab is all glory and glorious, provided we continue to focus on giving that care. And while our secretary, Dr. Sanjay Pandey, was telling us about the NMC issues and the challenges that we are facing with them, I think those are developmental issues and they keep coming in the life of every profession, every organization, and every individual. Those will keep coming and we will keep working at the organization level and at individual levels, and I'm sure we will achieve some success on those fronts as well in times to come. Having said this, I think today is also a memorable day, and I am extremely pleased that we have our own IAPMR textbook of physical medicine and rehabilitation. More than 100 authors have gone in to write that book, and I think it was about a 5 to 7 year project to get that book out in the system, and we are hoping that such activities will continue. The activities of training postgraduate residents, not only that, we now have activities which are focused at providing training on single subjects. So when we have postgraduate programs running, many times one postgraduate does not get experience in all the areas because the practices in different centers are different. And that's the reason we as the association are taking up this responsibility to provide opportunities for postgraduates to come and get training in a capsule mode for areas where they are less exposed. All these are the responsibilities of the association. I'm sure that we will keep working for delivering those responsibilities, and with this I wish this conference a very good luck in happening it, and my best wishes for a successful and grand event. And I thank all the organizers for having taken up this responsibility on behalf of IAPMR. I thank the chief guest, Dr. Narayanaswamy, once again, and PSG Institute for giving us this wonderful venue and the excellent infrastructure that was awe-striking to me for hospital. Thank you once again. Thank you all the delegates. Welcome to Coimbatore, and long live IAPMR.
Thank you, sir. I now request Professor Tirunavukarasu to felicitate Dr. Ajay Gupta. Thank you, sir. Publishing a book is no mean achievement, and the IAPMR, through the efforts of several people who have worked very hard, have managed to reach this milestone of publishing a textbook of physical medicine and rehabilitation. At this time, we take this opportunity to honor some of the doyens in our field whose blessings and teachings have contributed to the publication of this book. I request our Honorable Chief Guest to please present a copy of the book. Professor A.K. Mukherjee, please. Professor R.K. Srivatsava. Professor R.K. Srivatsava. Thank you, sir. Professor Nandakumar Nair. Thank you, sir. Professor S.L. Yadav. Thank you, sir. PMR today is a growing specialty and still needs to grow more. Research is one of the main foundations on which a medical specialty grows. And I think our specialty needs more research and more investigative work by our PGs and all the academicians and clinicians. Today at the hem of the MGR Medical University, we have a man who is very keen and dedicated and interested in research. And I'm sure under his able stewardship, we will find PMR growing in leaps and bounds in Tamil Nadu. It is my pride and honor to welcome Professor Dr. K. Narayan Samy, Vice Chancellor of the Tamil Nadu Dr. MGR Medical University, to deliver the Chief Guest's address.
Good afternoon to one and all present here. First of all, I congratulate the entire team, those who have been involved in the writing the textbook. It is a very rare to see that we have been, everybody is following that we've been Western textbook. It has not been taken into the considerations of our real cases and other concepts what we have been practicing that. So I once again on behalf of the Tamil Nadu Dr. MGR Medical University appreciate and congratulate the entire team those who have been taken in the great part. This is one of the momentous occasion. I think this is every association should have involved when they're taking part will be writing the textbook in their the Southeast Asia or Indian or in I can one step ahead you can try to follow that rare regional language so that the students can easily understand, get involved into the teaching and practicing and training that is everything into in their medical education curriculum. So I thank you very much once again the President and the Secretary and the organizing Secretary of Tamil Nadu chapter and everybody has been involved in this organizing a wonderful PMR conference. I respected Dr. Ajay Gupta, National President of Indian Association of Physical Medicine Rehabilitation, and I respected Sanjay Pandey, his Honorary Secretary IAPMR. I respected Professor Dr. Tirunavakaris is a Director of Government Institute of Rehabilitation Medicine in KK Nagar and Chennai. I respected Professor J. Kumar, the former Director of Government Institute of Rehabilitation Medicine Chennai. And I respected the Principal, the Dr. T.M. Subbarao, the PSG Institute of Medical Science and Research, PSG Hospital. And I respected Dr. J.S. Bhuvaneshwaran is a Director of PSG Super Specialty Hospital, Coimbatore. Respected Chella Kumarasamy, organizing Chairman of this national conference. And I respected Batma Rani is organizing Secretary of this conference. The heads of the department, members of the faculty, invited guests, delegates, ladies and gentlemen. At the outset, I am deemed it on honor and privilege to be the chief guest on the occasion of this momentous occasion of the 52nd meeting of the Indian Association of Physical Medicine and Rehabilitation conference being held here with the theme on the PMR 360 degree under the auspices of Tamil Nadu chapter of IAPMR at Coimbatore. You know that it is a city known for its industrious spirit, vibrant culture and warm hospitality. As we gather here today, it is crucial to reflect on the history of the physical medicine and rehabilitations. A discipline that has evolved ever old time to become the beacon of hope for the individuals facing the physical impairment or disabilities. Rehabilitation is about bringing back to the lost abilities to normal or near normal, consistent with its problems. Enhanced quality of health care and increase the expectancy, life expectancy come with the issues about the quality of life. These challenges is especially relevant to the physical medicine and rehabilitation. That is a PMR specialty focused on enhancing that is the quality of life with the increasing burden of chronic disease and disabling conditions. Requirement for a PMR specialist will increase. Healthcare in India faces newer challenges, especially predominantly concerning the conditions affecting the geriatric age group and the increasing the prevalence of the non-communicable diseases. Enhance the quality of healthcare has resulted in a population living longer than ever before. However, the increased life expectancy comes with the issues about the quality of life. I think the older adult often require a more complex and long-term care, the PMR specialist plays a crucial role in the national health care, and the PMR specialist will find themselves in a higher demand in times to come, and therefore it is vital to equip them with a skill set, and that is likely to be required in times to come. The primary care physicians are typically the first point of contact for the patient, intervening the pathology of the illness such as major disease, diabetes mellitus, where the impact of the impairment of such as sensory loss, ulceration, contractures, and quality of life. Such a difficulty in walking must be considered, and with the active support of the primary care physicians in the form of collaborative effort with the PMR specialists, so that the functional outcomes will be easy to achieve to their fullest potential. PMR specialists strive to improve the quality of life by improving the functional outcomes, while also treating the underlying the various technology has significantly enhanced our diagnostic and therapeutic capabilities. The tele-rehabilitations, another aspect. The tele-rehabilitation digital health, for instance, has emerged as a powerful tool, breaking that is down geographical barriers. That is will be the ensuring the patients in remote areas have access to the expertise of the PMR specialist. Virtual reality and augmented reality, the applications are revolutionized in the rehabilitation exercise, providing the immersive and the interactive experience that enhance the enhancement of the engagement and outcomes. The advancement in the neuroprosthetics and robotics are offering the unprecedented opportunity for patient with the limb loss or paralysis. The exoskeletons and robotic assisted devices are aiding the rehabilitation efforts, promoting the mobility and improving the overall quality of life for our patients. And finally, the last, it is I think it will be this one of the important tool everybody is now have been expected to the every disciplines, artificial intelligence. The utilization of artificial intelligence in a PM also is transforming how we analyze and interpret the data. As we embrace the theme of a PMR 360 degree, let us continue to explore every angle, leaving no stone unturned in our quest for the excellence. So may this conference be a source of inspiration, collaboration, and innovations, propelling us forward into a future where the possibility of PMR are boundless. I further wish this conference of 3 days would give an impetus to the stakeholders and academia to give a shape to the outcome of the conference. Thank you very much.
Thank you very much, sir. We hope that your suggestion of PMR being incorporated into all primary care physicians' competencies would translate into PMR becoming a mandatory competency for undergraduate curriculum. I'm sure with your support and help that would fructify soon. Thank you very much, sir. I now call upon our National President, Dr. Ajay Gupta, to declare the conference open.
We have this 52nd Annual National Conference of IAPMR open.
I now call upon Dr. S. Padmarani, the Organizing Secretary of IAPMRCON 2024, to deliver the vote of thanks.
Just a second, sir. I just requested Professor Narayana Swami, Vice Chancellors, to come. Yes, because I want to invite our dynamic editor-in-chief who began the whole hard work. Want him so that he has to be facilitated from with an instrumental person who began the book. I call upon Dr. Joy Singh to come onto the stage, please. The most dynamic academic committee chairman and the editor-in-chief who began the wonderful book of IAPMR, whose efforts couldn't be a reality.
Good afternoon to all the delegates who have gathered here, who have traveled from various places. And it's indeed an honor and privilege to me as the Organizing Secretary of IAPMRCON 2024 to host this prestigious event that brings together the experts and enthusiasts in our field of physical medicine and rehabilitation in Coimbatore, the Manchester of South India, hoping the delegates can enjoy its ethnicity and scenic beauty. I extend our wholehearted, sincere thanks to all the senior physiatrists who have gathered here and our chief guest, Dr. Narayana Swami sir, and the guests of honors, Dr. Subba Rao sir and Dr. Bhuvaneshwaran sir, and our national president of IAPMR, Dr. Ajay Gupta sir, and Dr. Sanjay Pandey sir, our secretary of our national president, and Dr. Tinnaukarasu sir, the director of GIRM, KK Nagar, Chennai, and Dr. Jayakumar sir, the past retired director of KK Nagar, Chennai Rehabilitation Institute, and all the ICMR NLEAP regional consultants who have gathered here, who have extended their support of ICMR also to our 52nd IAPMRCON 2024. And I wholeheartedly thank our organizing team and the scientific committee patron, Dr. UN Nair sir, and the chairman, Dr. A.J. Rajendran sir, and Dr. Naveen sir, and our workshop committee chairman, Dr. Uday Singh sir, and Dr. Ramamurthy sir, who has all the way he was with us in getting this conference done in a very smooth and very pleasant manner. And on behalf of Tamil Nadu chapter of IAPMR, we celebrate the 52nd annual conference of IAPMR that is reflecting the rich history of our gathering and the profound impact it is having on the shaping the future of our discipline, owing to the theme of our conference, PMR 360 degree. And I also want to extend our appreciation to our sponsors, volunteers, and the organizing committee, and our postgraduates who have helped us in getting all these things done in a proper way. And together we embark on a journey of knowledge exchange and collaboration. And thank you for making this inaugural session a resounding success, and hope we are en route to a memorable conference with all your blessings and your wishes. Thank you for all the support. Thank you.
Thank you, Madam. This brings us to the end of the program. I request all the delegates and dignitaries to please rise for the national anthem. Lunch is being served on the right-hand side of the hall. Please join for lunch.
afternoon to all. We are starting our scientific session number 3. I request the chairpersons, Dr. Yu Singh sir and Dr. Naveen sir, to come to the stage to chair the scientific session. Thank you, sir. I request our first speaker, Dr. C. Tyagarajan sir, from National Spine Injury Center, Stroke Mandeville Hospital, Aylesbury, Buckingham, UK, who has come all the way from UK for attending our conference. I welcome you, sir, to deliver your speech.
Good afternoon, respected chairpersons, ladies and gentlemen. I am a physiatrist for 45 years and I'm 75 years old, and I've been on 44 years in spinal cord injury rehabilitation. When I look to the role of a physiatrist in 1979 and compare it today, I should say you have done very well. And thanks goes to all the senior colleagues in IAPMR, how you developed the scope from just a focus of anterior poliomyelitis rehabilitation or amputees. You are expanding now everywhere. So I thought to take this opportunity and provide another dimension of role you can play in home ventilation. Now, when you call our domiciliary ventilation, there are two types, invasive, non-invasive. But today's presentation is on non-invasive home ventilation because that is more practicable and you can start this service even from today. Now, when I Googled it, it does not mention about invasive. It is a non-invasive ventilation as a long-term. People who require some sort of a supportive ventilation at home for a long time, a physiatrist can play a role. Now, I took one condition which require home ventilation support, that is obstructive sleep apnea. The reason being, we are working with the spinal cord injuries. There we saw the prevalence is more than 3 times, but I'm sure in other conditions also it is applicable because the incidence will be more. Now, in other reason apart from the increased incidence, it is a predisposing factor or aggravating factor for ischemic heart diseases, resistant high blood pressure, increased insulin resistance conditions, predisposed to stroke, cognitive impairment, and of course, obviously, the road traffic accidents. So, where it fits in the international classification of sleep disorder, there are 6 major categories, among which it comes in sleep-related breathing disorders. There are 3 conditions, but the more easy to diagnose, easy to manage is obstructive sleep apnea. That's what we are going to discuss. Now, what is obstructive sleep apnea? It is some breathing difficulties or disorder which is associated with the next day excessive daytime sleepiness. So that is labeled as the obstructive sleep apnea. The reason being, while we are sleeping, the airway collapse, so the air entry had a trouble, so they are not able to sleep properly. Even though you don't wake up, if you do the EEG, it shows the arousal. Now, so this is the condition. What we are doing is just a practical presentation to show you how you can start the practice even after this lecture. So as conventional, we will have a subjective compliance, and then we will have a subjective scale. That is Epworth scale. You can see it in the Google, you can see it. And then we do a objective measurement, that is a overnight sleep study. This presentation is going to show you how we simplified the overnight study so that you can do it in their home environment much more easily. Now the futures, the important cardinal symptom is excessive daytime sleepiness and the morning headache and various day-to-day activities they doze. So that is the very important, and another obvious thing is the snoring. So that is the subjective feature. Then the subjective measurement is, it quantifies the severity of excessive daytime sleepiness. There are 8 activities, each one is scored 1, 2, 3, so 24. If you get more than 10 on the score, then you got a severe excessive sleepiness. Then we made an outcome score. Here we put a daytime activities is individualized, and then you see how often the sleepiness is disturbing their activities. Then when you give the management, that moves from the right side to the left. So some people have always the problems dozing while we are talking to the people or watching the TV. So it is the outcome measures where you give a management and then see how they are progressing. Now, so by subjective, just taking the history and the subjective scale, one can diagnose they are susceptible obstructive sleep apnea. Then we are doing objective measurements. The gold standard was polysomnography. It is difficult to do it because there are so many things to connect. We can't do it as a home environment. So before we go, what are we measuring with this instrument? What is the parameters we are going to see is, there are 2 factors we are seeing. One is called apnea. Say here, the airflow is measured through the nasal catheter and put a band on the chest and abdomen. Here you see the airflow is completely stopped, but still the chest and the abdomen there are some movements. So this is called apnea. So equal to or more than 90% of reduction in airflow, and it happens for 10 seconds. The machine recognized as one episode of apnea. And also the oxygen saturation falls down below the 4% below the baseline. Then the apnea is not completely stopped, but the ventilation is reduced about 30% or more and sustained for 10 seconds, and the saturation is less than, the falls below 3% or 4% of its baseline. Now, there is another condition called central apnea we are not going to discuss. The difference is, in the central apnea, there is no airflow, there is no thoracic movement, there is no abdominal effort. That means the problem is coming from the central, you don't get any effort to overcome the problem. Whereas in obstructive sleep apnea, the flow is stopped, but still the chest and the abdomen trying to compensate that. Now, as I already explained to you what is apnea and how the machine is calculating, then we put, that is the cannula here, connected to the machine, and then the pulse ox. So we are measuring the flow, air flow, and the oxygen saturation. It put the pulse rate as well, so you don't need a polysomnography. So that gives you the apnea, how many times the apnea happening per hour, how many times hypopnea happening, then it makes the index, apnea, hypopnea index. So here you can see that is the saturation. Here it's falling down and the heart rate is increasing. There the flow is reduced. So very clearly you can see it. That's just in the early morning, same thing you are noticing here. Then in addition to the apnea, hypopnea index, you can get with the pulse oximeter, oxygen desaturation index. What does it mean? How many times in an hour the saturation falls below 3% of the baseline and it's sustained for 10 seconds. So the number of times you get the desaturation is ODI. The interesting fact, both are linearly related. So we were making a research to find out, can you do only a pulse oximeter, oxygen desaturation and diagnose? I'll show you in a minute that investigation. So I explained these two index. The way it's graded, more than 5 is a mild, more than 10 moderate and severe. You need some sort of non-invasive support for moderate and severe. Oxygen saturation is the same scoring system as I told you earlier. They are linearly related. Now we have more and more after the COVID, every house got a pulse oximeter. So we thought that should be we can manage without elaborate test. So we did put a poster presentation to increase the awareness of the people, and we showed we don't need a compared polysomnography and check the airflow and the pulse oximetry, and we show the more accuracy we can get in diagnosing and assessing the severity. Now, as I said, we decided to see whether we can manage only with pulse oximeter. So we did what's the two-stage model. What is two stages? First stage, a simple questionnaire. 6 questionnaire takes about 5 minutes, and then you give a pulse oximeter to do it in the night so that you can have an oxygen desaturation index, so that you can diagnose and see the severity and you can manage. So we produced that in the article. It is a multinational research, Canada, Australia and England, and we produced a paper in Thorax, and I showed that's more reliable and the subjective scale is validated, and that's the instrument, pulse oximeter. And even you can have it like that, or you can use the ordinary one as long as we get a small software which calculates the oxygen desaturation index. So again, this is the graph which shows on the top the 24 hours saturation one. If you zoom a particular area, you can have a look at it, but as I told you, it calculates per hour things. You can set the percentage of how much fall you are going to call it as a one episode. You can put 3% or 4%. The American Association put they said you can put 4%. Now that is the questionnaire. Next are temperatures and the age, Asia level, daytime sleepiness, subjective scale, do you snore, and then is there any breathing disturbance. Then you do the overnight sleep study, you see the desaturation index, and then you score. According to the score, you know the severity. So the question is, what is the treatment? Treatment is very simple. You just continuously push the air through the windpipe or trachea. That's the device. It's not expensive, and by the mask, and it's all connected digitally. That means you can get through the internet the results to your house and or the hospital, and also you can modify the parameters from distance.
Only 1 minute.
Okay. Now this is the one we showed, and this is the response to the earthquake. So what I am trying to tell you is a framework. The patient or anybody comes to you with a daytime sleepiness and they are tired and headache and everything. You put that 6 questionnaires of the 6 items and do the pulse oximeter and see the oxygen desaturation index. Then you will get the result. You can treat him. Now what we are doing now is we are applying the AI so that the machine learning model learns and it moderates and do the follow-up on a regular basis. So I think it's worthwhile thinking about this as a physiatrist, as a role. In the long run, probably in 10 years' time, you may take an invasive. In invasive, you can have a mechanical ventilator, electronic ventilator, phrenic nerve stimulators, direct diaphragm stimulator. All these people after that need a long-term follow-up. So that is there's a golden opportunity to take this role. Thank you very much.
Thank you very much, Dr. Tyagarajan. Are there any questions from the audience? Yes, Dr. Geeta.
accuracy is required when you are diagnosing some critical things like physiological values. Here it's a relative scores. So it is accurate, right? We don't go on that path because we don't need that. So like COVID, when they measure, they are not going with one value. That's why I said you put in a person, see the baseline with that instrument. If the baseline shows, say, they are all the time it's the 94, then what the machine is looking at it, if you said 3% fall, so anything falls below that 91 or 90, then it calculates as 1. So it always takes a baseline as an individual. Yes, but what they have done in Israel and Spain, they developed what is called Oxynet. You can put it in Google. That provides all the softwares and everything. You can do it. It's very easy. It's not expensive instrument, and then you can do it. So what we are saying here is, the message here is, now it is simplified to a level we can practice. The cardiologists are learned from me now. The cardiologists are doing as a screening because they believe the ischemic heart disease. They need to know the obstructive sleep apnea condition. So I'm sure various other neurological, even cerebral palsy, I feel the awareness should come.
Thank you very much, Dr. Tyagarajan. It's really wonderful to hear from you. Thank you. Such a wonderful talk. Now we look forward to having Dr. Srikala come and talk about the gender bias in rehab. So we'll like to learn whether it's really a myth or a reality.
Actually, this is a very relevant topic. Recently, all government employees have gone under Karma Yogi, this thing, and there was one course on this also. I think we should listen to it. It's very important.
Good afternoon, everyone. This is not a scientific topic, actually. I would rather call it a social science topic. And I have presented it sometime back in a state conference of Kerala chapter. And those who have heard me earlier, please bear with me, because there is a little change I have made. Gender bias is the tendency to give preferential treatment to one gender over another. And the concept of gender bias in healthcare and rehabilitation refers to differences in treatment which are not medically justified. There are different definitions given by so many people, starting from Sigmund Freud. So many others have defined it. But I find this the simplest available. So I would like to define it this way by Risberg, Johansson, and Hamburg. There are different types of gender bias, mainly alpha bias and beta bias. And alpha bias emphasizes the psychological difference between men and women, while beta bias, just the opposite of alpha bias, minimizes the differences. And alpha bias perceives men as superior, androcentrism. Being a woman, I would like to look at this topic from a woman's perspective. So please don't brand me as a feminist, I'm not one. Key dimensions of rehabilitation, as you know, are availability, accessibility, affordability, and acceptability. And gendered barriers exist across all the 4 dimensions. Treatment in many situations is influenced by gender attitudes discriminating against women. Maybe it's a conscious thought, or you may be totally unaware that it's influencing your behavior. know that every year we celebrate Women's Day on 8th of March, and last year, 2023, the theme was Accelerating Equality and Empowerment. Collective action can make a difference. But just think, where are we in India in closing the gender gaps? And what are our efforts towards alleviating gender discrimination? There are certain points to ponder. In Indian scenario, it's a male-dominated society, as all of you know, and the primary duty of a woman is a caregiver or homemaker. And we have very strict family roles for a woman, that of a daughter, wife, daughter-in-law, mother, mother-in-law, grandmother, and cook, homemaker, lawyer, judge, doctor, nurse, teacher, and whatnot. Being a woman itself is considered as a disadvantage. You can see that while working, the woman is carrying a baby on her back. Recently, I read a book, One Little Finger. I don't know, many of you might have read it already. It's the story of a woman who defies all odds to emerge successful in spite of her crippling disability and an indifferent society. Malini Chib writes in her autobiography the struggle she has undergone to establish an identity in the society. As you see on the cover page, she is suffering from spastic cerebral palsy. She has movement problems as well as speech problems, and she says speech problems are more crippling than movement disorders. So she says a woman with disability has double disadvantage: the oppression of being a woman in a male-dominant society, and the oppression of being disabled in a society dominated by able-bodied people. And she mentions about Susan Randall, a US feminist writer and researcher. She calls the woman with disability as a rejected body. And women with disability have the same thoughts, desires, feelings, passions, and expectations like any able-bodied person of their age group. This we all tend to forget at times. And I'm sharing some real-life experiences here. Women with disability from different socioeconomic strata suffer consequences of different disability in different ways. So I would like to give some examples from my experience. This was some 20 years back. As part of our community-based rehabilitation project, we had to visit a house in Trivandrum. Here was a 55-year-old woman, a divorcee, who had a 20-year-old daughter with spastic CP and mental retardation. And she wasn't married, and this unmarried CP girl had a 2-year-old daughter, and she had undergone MTP twice earlier, and the mother pleaded to get her daughter sterilized. This is a story based on a girl with disability. The woman's husband divorced her just because she had given birth to a mentally retarded child, and the daughter was sexually exploited by men in the neighborhood in her absence, as she had to leave home for a livelihood for herself and her daughter and granddaughter. She wanted her granddaughter to be taken to an orphanage because she didn't want history to be repeated. So if the CP child was a male, just imagine, the man wouldn't have divorced her, and even if divorced, she would have had a peaceful life with her son. And there's another true story. A lady diagnosed to have a spinal tumor at 32 weeks of pregnancy. She underwent surgery at 34 weeks of pregnancy, excision of the tumor and cesarean section. The mother and baby had to be in the ICU, of course, for different reasons. The baby was premature and she had post-operative paraplegia. And the baby could be discharged after 2 weeks, but she had to remain in hospital due to post-op paraplegia, and she had naturally bowel and bladder incontinence. So before settling that, she couldn't be discharged. So she had to remain in hospital for some more time. And the baby was taken care of by a maid, and the lady developed recurrent tumor after 3-4 months, and she underwent radiation and was mostly wheelchair bound, dependent for many of her ADLs, and her husband divorced her. She did not develop sufficient attachment. The child did not develop sufficient attachment to the mother, and sometimes did not even recognize her, and she was very much worried over that. And just imagine if the patient was a male with paraplegia. The dedicated wife would have looked after him 24/7. She would have earned a living for the family. She would have looked after the in-laws and the children. She would have remained a loyal wife throughout and a good homemaker. So the implications of disability are different and different socioeconomic strata, I told you. I know a lady doctor who had severe congenital kyphoscoliosis, and she's unmarried probably due to her disability. And she developed carcinoma of the breast, and she's still undergoing treatment. She's being looked after by her 75-year-old mother. And the mother prays, I heard her praying that she should outlive her daughter, because there is nobody to look after the cancer-affected daughter if she's not there. So if the patient had been a male, even with the disability, he would have married a normal woman, and they would have had at least 2 children, and they would have looked after him, and the focus of the whole family would have been on him. And a man with disability is considered as a wounded male. I told you, Susan Randall has written that the disabled female is a rejected body, whereas a disabled male is considered as a wounded male. And these are stories of women from different socioeconomic strata, but the discrimination against a woman with disability is very obvious. And they are considered as a burden to the family, that it's a female. And each situation warrants a different type of solution, because the scenario is different in different houses. And there's no room for any sentiments. Follow your heart, but take your brain along. A woman with disability has many problems like physical, psychological, social, economical, cultural, and even legal. A woman with disability suffers twofold discrimination, as a woman and as a person with disability. And they are the most marginalized group, and they are less likely to be educated and employed. Globally, if you look at the statistics, the literacy among disabled is 3%, and that among disabled women, it is less than 1%. They have poor access to health care, and they are more vulnerable and are at a greater risk of violence, injury, abuse, and neglect. And winning over a disability needs tremendous willpower, perseverance, and hard work. And they need family support, social support, and support from authorities. I'll give you some examples of successful women who are well rehabilitated. Helen Keller said, when one door of happiness closes, another opens. But often we look so long at the closed door that we do not see the one which has been opened for us. That is Sudha Chandran, lower limb amputee. She's an actress and a dancer. She is Arunima Sinha. She probably, I'm not really sure, she's probably the first lower limb amputee who conquered Everest. You know how she lost her limb, many of you might have heard, and some of you might be involved in rehabilitating her also. She was actually, to start with, she was a hockey player, and after winning a match at Lucknow, she was going back by train to Delhi. And during the travel, somebody snatched her bag, and during the fight, she was pushed out of the train, and she fell in between the train and the platform, and she lost her limb. That is Vaikam Vijayalakshmi, a blind playback singer from Kerala. That's Vandana, Mohiniyattam dancer. She dances on one leg. That is Supreet Kaur, a model. She's a lower limb amputee. And that's Dr. Mary Varghese, every one of you may be knowing her. And she was wheelchair bound. Somebody has described her as the wheelchair surgeon in the morning. She was head of the department of PMR for a long time in CMC Vellore. She is Tani Gray, a wheelchair racer. That is Deepa Malik, another swimmer basically, but she won so many international medals for India in throw items. And she said, I didn't have any footprints to follow, no role models to look up to, and no signboards on the path. I had to explore and find my way. I don't want anything to change. This is an interesting voyage. To say this, she must have very good determination and a very strong will. And that is Alexandra Kudos, another model on wheelchair. That is Abani Lekhara. She won a gold medal in the last Tokyo Paralympics in 2021 in 10-meter rifle shooting. That is Rabia, a social reformer. She is a congenital kyphoscoliotic lady. That is Vidali Modi, again another wheelchair model. She said the railways treat the disabled as a piece of luggage, and this needs to stop. And this is how her petition goes. I have been manhandled 3 separate times by the porters. They were helping me board the train because Indian trains are not wheelchair accessible. I'm a disabled woman living in Mumbai who loves to travel. She is a wheelchair India runner-up in 2014. She's a motivational speaker and a model. She has been paraplegic from the age of 14 after a car accident. Portable ramp, wheelchair, and lifts are made available in the Central Railway Station Thiruvananthapuram on her complaint. We should be proud of her. These are some women who are successfully rehabilitated. There are hundreds of disabled women who have no access to rehabilitation services, still remaining in the dark, not knowing which direction to go. And all man-made structures are for the normal, healthy adult male. If you look at any man-made structure, it is so. And a vast majority of women with disability are neglected. And many women are dumped into the dark corners of their homes or institutions. And they are subject to gender-based violence, maltreatment, sexual abuse, neglect, and exploitation. And they are teased, taunted, and looked down upon women is of a primary caregiver in the family, and stereotypical thinking is that a disabled woman cannot do that. But it is easier for a disabled man to get an able-bodied partner, not so for a female with disability, because they are considered as wounded men who deserve all the care. Most disabled women are dumped into care homes, and they have to go through the inherent peculiarities. And now what can they do for themselves? They have self-help groups. They do designer kitchen. Now, if you look at the Rights of Persons with Disabilities Act 2016, certain offences are punishable, like outraging the modesty of a woman with disability, sexual exploitation, voluntarily or knowingly denying food, etc. So there's a UN Charter which came into existence from 2006, and India also signed it in 2010. Now, if you look at the Indian literature, the earlier literature do not provide earlier legislature do not provide any gender component, but latest legislature gives due importance.
Time is over.
Sorry?
Time is over.
Okay. There are certain movements world over. So women never give up. Thank you.
Thank you very much for your lucid presentation. Because of positive time, we are going to next speaker directly, because any one question we can take.
We definitely see a bias against the women, of course not disability here. So thank you very much. It was really very illuminating to learn about what we feel is not really a myth. It is absolutely true that we have bias against the women, specifically with disability. Thank you very much, Dr. Srikala. It's really been illuminating. Thank you. We now call upon Dr. Siddharth Rai from Lucknow to give his talk on osseointegration.
A very good afternoon, all of you, respected chairpersons and all my dear audience. I congratulate the organizing committee for hosting such a wonderful and enriching conference at the beautiful city of Coimbatore, and thank you for inviting me here for delivering this lecture. So my topic is osseointegration and overview. I would like to make a disclaimer that I don't have any personal experience working with osseointegration. However, whatever knowledge I have and I've gathered, I'm trying to share with you all. To begin with, I would request all of you to pay attention to these videos. So the initial first 3 videos are of the patients who are wearing the conventional socket wala prosthesis, and last 2 patients are those who are using the osseointegration prosthesis. You can see how easily the person has donned the prosthesis and how beautiful the gait is. There is better stability, better gait pattern of these patients. This is the prime advantage of these kind of prosthesis. What is osseointegration? It is the process by which living bone attaches to the surface of a load-bearing artificial implant, forming a structural connection. Osseointegration term originates from the Greek word osteon, that means bone, and Latin means integrate. It is a procedure in which the metal implant is directly anchored to the residual bone, which is then attached to a prosthetic limb using a transcutaneous connector through a small opening in the skin. So the metal implant is directly connected to the bone. That gives better control of the prosthesis, and more importantly, there is better proprioception for the patient, giving better stability as well. In brief, we'll discuss what was the need for these kind of prosthesis, what was the history, what is the basic science behind it, clinical application, advantages and disadvantages. So what happens with the conventional prosthesis? What are the issues? We all regularly see such patients, OPD patients, complaints of friction leading to ulcers, soft tissue trauma. Then in summers, there is always complaining of perspiration. Doctor, we cannot wear it regularly. The legs feel very damp. Then those who have short residual limbs are having some problems. Then there are issues with the fitting and volume fluctuations and poor stability. With the prosthesis, there is issues with the don off and timed up and go. There is error of alignment issues that happens with the person who is making the prosthesis. fitting issue, poor proprioception, and all these actually what it does is that a patient loses confidence in his gait. What is the basic difference between the socket prosthesis and the bone alignment, bone integrated prosthesis? In socket prosthesis, the weight of these prosthesis is borne by the tissues, the muscles, the skin, and the bone. Whereas in the osteo-integrated prosthesis, the weight is entirely borne from the residual limb of the bone, which again gives better stability, better mobility, and better proprioception. This is the major advantage. Now coming about the history, how this kind of processes were developed. This was Dr. Per Ingvar Brenmark, who is known as the father of osteointegration. He was basically a dental surgeon, and he coined very famous, coined the term osteointegration, and gave this line, "No one should die with their teeth sitting in a glass of water." So he pioneered the development of osteointegration in the dental processes. Dr. Brenmark's son was Richard Brenmark, who carried the legacy forward. He was a chief surgeon at University Hospital in Sweden, and he basically evaluated studies on rat, rabbit, dog, and then came to the humans, and did his first case on a 25-year-old bilateral transfemoral amputee in the year 1990 in the left limb and 1991 in the right limb. The basic structure of our osteointegration involves three parts. First is the living bone, second is the fixture, and third is the transdermal phase that happens through the skin. Now what is the requirement is bone should have a good vasculature. The better the blood supply, there will be better progenitor cells, better stem cells, better mesenchymal cells will come, and that will make the wound better and healing will be better. What happens is over the metallic part of this processes, bone tends to grow and it forms an alignment with that bone, with that part, metal part. So coagulum forms within first hour, and by the 12 weeks there is a proteoglycan layer. Fixture is the metal implant, the success of which depends on the type of material. Currently mostly titanium is used, however different alloys are also being experimented and used upon. Then depends on the surface coating and porosity. Now what happens if the metal implant is more porous, it helps growing of the bone inside the metal implant, which makes a strong junction with the thing part. However, there's a compromise for the strength and stability as well. Then it depends on the implant design, what is the length, width, and threads. Last is the transdermal interface, that is through the skin part. This part has got a major challenge of skin infection and skin ingrowth. I'll rush through the slide, I've got less time. So there are certain current implants which are being used all over the world. Now coming to clinical applications, where can we use? It can be used to eliminate all the socket kind of problems, the problems which I discussed in the first slide. It has direct skeletal attachment, so better stability and fixation. There's early and quick dawning. There is physiological weight bearing that gives to less energy consumption. Increase in joint range of motion, particularly the proximal and the hip joint. What happens because of this? There is improved gait and sitting comfort. It restores proprioception, there is better control of the limb, and enhanced mobility, independence, safety, and enhanced quality of life. Now, what are the conditions in which we can use and conditions where we cannot use? So long bone amputations from trauma or cancer are good candidates for osseointegration. Those who we expect will be having socket-related problems such as infection, skin loss, volume fluctuation, scar, can we go for this thing? And non-smokers. Contraindications, anybody who has got less vascularity with the bone, diabetics, smokers, peripheral vascular disease, elderly, pregnant ladies, those with radiation exposure, ongoing chemotherapy are not a very good candidate for this thing. Clinical applications, I like this term prehabilitation, which means before the initiation of this processes part, we go for training of this patient, we all know, which includes, to be summarized, core muscle strengthening exercises, muscle strengthening and proprioception training, and upper body training. All these assist in better control of the prosthetics. Now, this surgery, osseointegration, have got two types of surgeries. In type 1, it is in the one stage, everything is done in the same sitting. In second type, there are two-stage surgery. First is done in the first stage, and then after 6 months, the surgery is repeated. In one stage, fixture, abutment at index surgery, and process attachment, rehabilitation, all are started in the same go. Whereas in second stage, in first stage, fixture is done. We wait for 6 months for the fixation, and then we attach the abutment and the prosthesis, and then the rehabilitation is started. Each has got its own advantage and disadvantage. Post-surgery, how do we begin the rehabilitation? First is the initial loading. There is progressive weight bearing limited to few hours daily, increasing the amount of weight loaded to the prosthesis and the hours of weight bearing each day through the initial 3 months. We start with, for example, 5 kg of weight bearing on day 1, and we gradually keep on increasing till the day 14th, when 50% of the body weight is expected to be borne by the patient. Stage 2, we give a patient a prosthesis mostly the manual locking type of processes, and we start the training and gradual weight bearing for strengthening and balance and early gait training, preferably on parallel bars. In phase 3, patient is given the actual processes. Patients are encouraged to increase the prosthetic wear time, independent walking without crutches, and full weight bearing, possibly without a time limitation by the end of 6 months. What are the challenges with this technology? Often there is complaints of fracture in the bone, erosion and pain. There can be implant failure by loosening or fracture. Transdermal interface has got a potential challenge to all of us. First is, it acts as a source of infection, and there is always a case of skin ingrowth. Then there are torque impacts and limiting, and this process is quite costly. I did a survey and I found that it costs roughly $50,000 to $1 lakh US. How do we make sure that the patient we are giving has a success? Through following the proper indications which I discussed, thorough assessment of the patient's goals, lifelong dedication for care. That means the patient has to be motivated enough, multidisciplinary approach, and a dedicated program with the features of research, innovation, and long-term care, preferably at a research center. Osteoperception, it is the unconscious perception of the position of body, movement, and spatial orientation in relation to the external environment. This is the major advantage of this device. The patient can feel whether he's standing on this rug, or he's on a grass, or he's on a carpet or tiles. So that is major advantage. Patient can actually feel what kind of surface he's on, which gives better stability for the patient. There are certain studies which have given positive result for osseointegration. This study was in 2005. It says the individuals using a bone-anchored prosthesis have no restricted hip range motion with the prosthesis and report very few problems. Another study said that it increases significantly the walking ability and prosthesis-related quality of life. One study in 2019 said bone-anchored prosthesis led to improved performance and appeared to be safe. There are numerous studies. Future is all about monitoring how better we can design the processes, better 3D technology, better integration of the processes with the bone, and better transdermal interface. Because again, I said as before, it is a challenge for this kind of prosthesis. We need to improve the transdermal interface so there is better sensing, better impact and torque, and increase the proprioception, which gives more stability for the patient. Thank you.
Thank you very much for keeping in time.
Thank you, sir.
So I have 2-3 questions. But before that, any audience, somebody has. Okay. What is your experience? Have you?
So I said in the first slide itself, I got no personal experience. I just know there has been one surgery which was done in Mumbai by a surgeon. I am forgetting the name, and he did this surgery. The outcome was good, but long-term follow-ups are still underway.
Okay. I have another thing. Do you, going by your presentation, do you recommend only for transfemoral, or it can be upper limb, transtibial, any level?
It can be upper limb also, but the advantage of this is more when we weight bear through that processes.
This is transfemoral only, or transtibial also can be.
Transtibial also. Weight bearing has got relation directly with osseointegration.
Any other question? So thank you very much, Dr. Siddharth.
Thank you so much. Thank you.
We now call upon Dr. Divakar Mishra from. Oh, gulti ho gayi. I'm really sorry. Dr. Amit Kumar Malik from Guwahati. I'm really sorry.
Topic is doping and WADA guidelines for different sports.
Thank you, sir. Good afternoon, all in all, and respected chairpersons and organizers for giving me the opportunity to present my talk in front of this August gathering. I have chosen this topic as a physiatrist. You know, we used to see many patients. We used to prescribe the drugs. Many times it happens like you are prescribing some drugs to some sports personnel, and you don't know whether can be utilized by that particular sports person or not. So I took this topic to enlighten about the doping and WADA guidelines. First of all, what is doping? Doping is a term used for the prohibited drugs which can be used by the sport personnel to enhance the performance in the particular sports. So that is doping. If we go to the history is very long, starting from 1900s, still it is continuing, but some major incidences which happened are Seoul Olympics, 1988, Canadian track star Ben Johnson won the gold medal for 100-meter race. But later on, when he was examined, he was found dope positive. So the gold medal has been detracted from him, and the gold medal has been given to next second position one, that is Charles Lewis. Then next event is Diego Maradona. In 1994 Soccer World Cup, he used ephedrine to enhance the performance, and later on he was found positive, and in rest of the competition, after getting positive, he was taken out. But the major important turning comes in Festina affair in a cycling competition in France in 1998. After that, the IOC, International Olympic Committee, has done a meeting in Switzerland. Following that, this WADA agency has been formed. WADA is World Anti-Doping Agency. So WADA has come in act in 1999, and after that it has many branches throughout the world, and it is covering almost over 90 sports throughout the world. WADA has categorized the different drugs and substances in different categories. For understanding that, we need to understand what is in competition, what is out of competition. In competition is starting from competition to end, but that is not the complete one. Starting means one day prior to starting of that sports event to the finishing, then after that 1 day. So that is in competition period. And beyond this period, this is called out of competition period. So some drugs are in competition prohibited, some are in out of all time, and some substances or drugs are prohibited in particular sports. So the substances and method prohibited in all time list, it contains any non-approved substances. Means the substance which is being not approved by WADA to use. Or then next is anabolic agents. Anabolic agents, what it does, it increase the muscle mass and enhance the performance through that. In same way, peptide hormones also do same thing. Then beta-2 agonist, it increase the oxygen carrying capacity, through that the endurance used to increase because of this. Hormone also used to be like in same way. Diuretics are the drugs which are all time prohibited because it acts as masking agent. What it does, it clear out the drug which is being taken by the sport personnel. So it helps in clearing out the drugs. Then comes prohibited methods. So earlier only drugs has been covered. Now the drugs as well as prohibited methods. Prohibited methods include tempering of sample. Think that sample has been taken and the athlete has done some tempering with the sample. So that also come under doping now. So these are prohibited methods. So in competition, prohibited drugs list are long. The Broad categories are stimulants, narcotics, cannabinoids, glucocorticoids, and in method, sample tampering, I have already mentioned. And beta blocker is especially prohibited in particular sports that I will tell you later. This concept already I have told you what is in competition period, what is out of competition period. So the drugs can be specified and non-specified. What I told, specified will be in the list and non-specified will be in broader category. So both are equally important. Substances of abuse are the substances which are commonly used in society as abusive agents. So these includes cocaine, heroin, ecstasy, and tetrahydrocannabinol. Non-approved substances, I have already told. The drugs which are in preclinical or clinical development phase may be, or these are non-approved, so it cannot be used by any athlete. And the drugs which are being used for treatment of animals, that also cannot be used. So these drugs are all time prohibited. I told the list is long. Anabolic androgenic steroids, out of this very commonly used drug is nandrolone, ethylestenolone, metandrolone, so testosterone. Long list is there. With that, other anabolic agents are there. So lots of drugs are there in this list. Then peptide hormone, I have already explained. Then growth factors and growth factor modulators are also included in this list. I'm skipping this. Beta 2 agonists are being used commonly by the COPD and bronchial asthma patient, but in certain extent these are allowed. Means there will be some exceptions. Some beta 2 agonists can be used for therapeutic use. Those are salbutamol, formoterol, salmeterol. But the concentration is very important. The drug dose is very important. So maximum permissible salbutamol is 1600 microgram in 24 hours, or within 8 hours it should not exceed 600 microgram. For inhaled formoterol it is 54 microgram in 24 hours, and for salmeterol it is 200 microgram over 24 hours. So if we see here salbutamol, if it is in excess greater than 1000 or equal to 1000 nanogram per ml, formoterol 40 nanogram per ml in urine, if it is found any time, so this will be taken as adverse analytic finding, unless the athlete proves it that it is being used for therapeutic use. So these are hormone and metabolic modulator. Aromatase inhibitor, what it does, it inhibits the the formation of, or you can say formation of estrogen from testosterone. So in this way testosterone concentration will increase in the blood, so it will help to enhance the performance. Then one important drug is meldonium. This is very famous because of tennis star Maria Sharapova, who was found positive in her last games. After that she was taken out. Then diuretics and masking agent, already I have explained. Exceptions of diuretics are drospiridone and topical ophthalmic administration, that is carbonic anhydrase inhibitor, dorzolamide or benzolamide. These are exceptions. And other one is felsipressine in dental anesthesia. It is being commonly used. Methods I have already told. Blood and blood component tampering. One important point is, if the quantity has been taken greater than 100 ml through infusion route, it is all time prohibited till it is not proved by the athlete it is therapeutic use. I will skip. These are non-specified. Then actually it is huge topic, so I have tried to cover maximum things in this. Already time is over. It reduces the heart rate. So in some competitions which are static games like archery, shooting, underwater sports, so it controls the heart rate through which the concentration will be increased, then that can lead to enhanced performance. So beta blockers are especially prohibited in particular games. Star mark is given to the games which are all time prohibited, means these players, they cannot use beta blocker in any time, in competition or out of competition. So this is the list of beta blocker. These are my references. Thank you. I'll advise play true for you. Thank you.
Thank you for sticking to your time. Sir, any questions from the audience? Okay. Somebody.
No question is there. Yeah. I have one question, simple.
Sir.
The high altitude training or high altitude exercise, will that mount to, will that come under the WADA provisions or not?
Sir, I didn't get the question.
High altitude training, that also leads to enhanced performance. Will that amount to violation of WADA or not?
Sir, actually it depends on the medication what is being used. So yes, sir.
No. It doesn't come under the WADA guidelines, because there are academies which are now people are opening in the high altitude areas.
You can let the speaker, please. He is here. Let the speaker give the answer, please. Sorry. No.
Sir.
We can have discussion outside. One question I have for you: if somebody is on medication and he taking medication as prescribed medication, is that allowed, or he will not be means allowed to do?
Sir, actually it is allowed, but it is to be intimated to the association. So that is called therapeutic exemption. So use exemption, that is called TUE. Through that you have to take the permission from the organization, then it can be permitted.
Thank you.
Is there any way to check the urine salbutamol levels?
Yes.
Urine salbutamol levels, can you check it? Because there is dose prescribed for that also.
Yes, it is checked. WADA accredited lab is there, so that is situated in New Delhi. So all facilities are there. So if facilities are not there, then there is no way to check. So already WADA has situated their office in New Delhi, that comes under NADA. In India it is called NADA, National Anti-Doping Agency.
Thank you. So now next speaker, Dr. Ravinder Singh. He is from our ICMR, and he is going to talk on assisted products.
Namaskar, and thank you for inviting me to Indian Association of PMR conference. I think this is a different topic than what has been discussed since morning, and this topic is not actually well known among PMR specialists, rather medical professionals also. But no, this is an integral part of healthcare, so we thought that it would be important that to share it with the PMR professionals during the national conference. So this is the diagram of showing how disability and functional impairment they integrate. Because there were a lot of discussion going on since long, whether we are working in disability or whether we are working in the functional impairment. So what we discussed with the different experts over a period of time and came to the conclusion that we work on functional impairment, which is a much broader term than disability. And I have been talking to the person from experts from research, social justice and empowerment, that how does disability differ from functional impairment? Because disability is a social model term which is used in a wider term for the social issues also, like employment, education and accessibility, though accessibility falls under both domains. And functional impairment are purely from the point of view of health, as WHO has been defining it under ICF classification. Now, where the AT is required, we have chronic diseases which is increasing in number. We have increased number of older person to close to the 14% now Indian population. Born injury trauma, children with neurodevelopment disorder and learning disorders, mental illnesses, disabilities of course, then graduate cognitive decline and post-infection complications. So before we go to the classification, the assistive technology or assistive products are related to systems and services which are developed for the people to maintain or improve their functioning and thereby promote well-being. They could be any aids, appliances, equipment, instruments or softwares. So it helps the people to live healthy, productive, independent and dignified lives, and participation in education or labor market and to enjoy their social lives. Now going back to where does the assistive technology fall in the health sector? We have been talking about the health products now, which is a broader term. Earlier it was considered to be part of medical devices, but now we have been discussing it that it is not subset of medical devices, rather it is a total different area. It's a separate area than medical devices. So health product has 7 major categories which include drugs or medicines or chemicals, then diagnostics, then assistive product or assistive technology or assistive devices, then medical devices or medical technologies, and then vaccines, blood cell and gene therapies, and health technologies or digital technology or internet based health systems or IoT and telemedicine. Everything comes under the 7th category. So as per Gazette notification, any assistive technology as per Gazette notification of 2020 and later on the draft bill of medical devices, drugs and cosmetics act bill 2022, these assistive products has been considered as a medicines. So now the doctors have the right to prescribe any assistive technology as a part of their practice. Earlier we used to say that healthcare continuum contains 5 parts, but now in collaboration with WHO, the 6th part healthcare continuum has been proposed, starting with promotion, prevention and therapeutics or clinical surgical management, and then rehabilitation and assistive care, which include assistive technology and then palliative care. So this is widely used now, healthcare continuum. and some of the common assistive technologies which are used by the older person, because old age and child population, they have different needs, and the technologies are also different. So now WHO in 2016 published a list called APL list, Prioritized Assistive Product List, where there was 50 products for different functionalities. Looking at that list, we took up the challenge, and we have now started working on this national list of essential assistive product on the pattern of national list of essential medicines, which defines those products which can be provisioned through healthcare systems. So once it is included in an essential list, so it becomes the obligatory for the government to procure it and provision it through the health system, through government health system or public health systems. So national list of essential assistive product to 2020 contained 380 product, which we thought was the first step or step 0, from where we went on to prioritize it and come out with a shorter list, which is now 21 product, through a wide consultation and involving 13 type of stakeholders, which included the different professionals, different sectors other than medical sector, manufacturing sector, and the people, users, and the user communities. So all of them, they were involved to come out with the list of 21 products. The global report on assistive technology is a major document by WHO, wherein we had large contribution from India, from ICMR, and some of the other authors which had done the work in this area. So this process which was used for prioritizing 21 products, this is the inverted funnel method, and then these are the 21 products which are listed there. This document is available on ICMR website. Anybody can download it and use it for their purposes. So currently it includes mostly the very basic product which are very cost effective, which are not expensive, and by which the large number of people will get benefited. So the criteria was very strict, so that's why there are only 21 products, and maybe once that 21 products are saturated, we will go on to the next level of the list, maybe beyond 21, and then maybe 10 more or 20 more or 50 more products. So now we are working, creating an ecosystem surrounding these 21 products. We have already talked to the Bureau of Indian Standards for creating the standards. We have talked to the manufacturing sector. We have talked to the training part of these products through different medical colleges. It will be through CHEB, Central Health Education Bureau, which has taken up the responsibility for training and for awareness part. Then innovation part, for which already we have put up lot of money in different organizations and different institutions. Some of them are National Center for Assistive Health Technology at AIMS, Delhi, IIT Delhi, IIT Madras, Nish Trivandrum, and Saksham NGO, where lot of innovations are being done, and we are coming out with the new products, bringing out the new solutions. Then another, these are the objectives of NCAT. Then Center for Advanced Research and Excellence for Disability and Assistive Technology at IIT Delhi and AIMS Delhi, where they are creating an exoskeleton for post-stroke upper limb rehabilitation, which is using AR/VR also, and they are connecting it through different systems for remote controlling, tele rehabilitation also. So we have talked to the Andhra Pradesh Bedtech Zone for creating a manufacturing ecosystem in India, where they have already taken up the challenge, and they have developed a huge center for development of assistive product and assistive technologies. And ICMR through WHO, through DHR, Department of Health Research, has signed an MOU with the WHO headquarters for strengthening assistive technology not only in India but across whole of the globe, because we have taken so many steps which are now no other country has taken. So we have become almost the leader in this area. We will be feeding into the great report which will be published, second edition of which will be published in 2026. So we are collecting the data through RATA tool, Rapid Assistive Technology Assessment Survey tool, which will be fed into the global report. And also very important, just it's a matter of few days, WHO had asked us to propose International 80-day, and we have already moved the file, and that file is with now Ministry of Health and Family Welfare. Thank you.
Thanks for completing within time. Any questions from the audience? So, sir, I can have asked one question. Sir, you told that stakeholders have been involved. So, whether the population who are using it, population with disability, they have also been involved in this discussion?
Absolutely. We have used the blind, we have used, we have invited people with wheelchair, we have invited people with prostheses and orthotics. All of them, they were part of the consultative process.
Actually, to tell the audience, Dr. Ravinder Singh has developed a method of actually working on it. The research technique he has used is unique and is patented also, I think.
Yes, the 3-4.
So that's a unique technique he has developed. And the next thing after this talk, it is one of the sensitization and discussion and dissemination. But the important thing is that we are going to have discussion in the Jade Hall in a very short while. So starting 4 to 5, I think we have a small group.
So anybody who is interested,
welcome people to come in large numbers and have a good discussion on something new which ICMR is doing.
Earlier we thought it would be a panel discussion, but now I think it should be an open house discussion.
Open house, yes.
Yes. Thank you very much.
Thank you very
All
much
are
indeed.
We are very lucky to have you here. So, and now we will next. Thank you very much, sir. Now we invite next speaker, Dr. Sandeep Kumar Gupta from KGMU, Lucknow. He is going to talk on differential pulmonary function among children with CP according to level of GMFCS.
Good afternoon to all of you. Now I am going to present a small study on differences in pulmonary function among children with cerebral palsy according to their gross motor functional classification system, also called GMFCS classification system. As we know, CP is the most common cause of childhood disability, and the incidence is 2 to 2.5 per live birth. Along with motor disability, children with CP can have abnormality of respiratory function, such as a poor airway clearance, respiratory muscle weakness, and lung distensibility. These symptoms are caused by consequences of neuromuscular impairment resulting in the developing brain. Children with CP breathe in poorly coordinated fashion, relying on abdominal muscle instead of the chest muscles. As we know, clinically most movement-related disorders have traditionally been classified according to type of muscle tone abnormality, like spastic, ethioid, ataxic, and mixed type of CP, and the anatomical involvement of limbs, that is hemiplegic, diplegic, and quadriplegic. The gross motor functional classification system has been widely adopted in clinical setting for evaluation of functional level and motor ability in children with cerebral palsy. It is classified in 5 level. The chest movement is restricted and chest muscles are weakened in cerebral palsy children. The ability to take a large breath is impaired. The shallow and low breathing volume in severe CP lead to the development of widespread microatelectasis, and the decrease in lung distensibility can lead to the children with CP at risk of developing significant parenchymal disease and respiratory problems. The rationale for this study is the best of our knowledge, little evidences regarding differences in respiratory function depending upon the GMFCS level in CP has been published. In the current study, we attempted to determine whether a difference is in respiratory function according to level of GMFCS is found in spastic cerebral palsy children or not. The aim of the study is to assess the pulmonary function among different GMFCS level and to find out the difference in pulmonary function parameter across GMFCS level on following parameter like forced vital capacity, forced expiratory volume in 1 second, and ratio of the FEV1 and FVC, peak expiratory flow, and tidal volume and chest expansion. Briefly about the pulmonary function is a test group of tests that is measure how well the lung take in and release air and how well they move gases such as oxygen from atmosphere into the body circulation. For most of the test measurement, you can breathe normally and quietly, and other tests require forceful inhalation and exhalation after deep breath. It is a cross-sectional analytical study at Department of PMR of Tertiary Care Hospital in North India, and we choose 37 cerebral palsy children who satisfy the inclusion and exclusion criteria. Entering the age, gender and height into the computerized spirometer, instruction was given to the subject about how to perform test before testing, and the pulmonary function testing is done in sitting position only with back rest. Minimum 3 attempts were taken for testing, and chest expansion is measured at the level of 4th intercostal space in sitting position. These are the exclusion and inclusion criteria. The inclusion criteria diagnose spastic cerebral children. Age is 5 to 18 years of any gender, and GMFCS level 1, 2 and 3. GMFCS level 4 and 5 were excluded, and the cognitive and lung ability not sufficient to perform respiratory function test are excluded, and any obvious chest deformity and kyphosis or scoliosis was also excluded. The spirometer is gives the predictive value of different lung volumes and capacities are calculated after entering the parameters of height, age, weight and gender. Result was expressed as a percentage of predictive values and in liters and liter per second. A value of usually considered abnormal if it is less than 80% of predictive value. These are the statistical tests we used in this study. Out of 37 children, 7 children in GMFCS level 1, 19 in GMFCS level 2 and 11 in GMFCS level 3. These are the mean values with sample size in each group with assessment parameter. The values which is highlighted green have a only significant difference between the groups by the ANOVA test, like chest expansion, forced expiratory volume in 1 second, forced vital capacity and vital capacity, and peak expiratory flow. The FEV1 in the level 1 is almost in the normal range, 71%, and in level 3 is 53.7% of the predictive value, while the forced vital capacity in level 3 is 52.91% of the predictive value. And the ratio is almost similar in all the GMFCS level. The peak expiratory flow over the 25 to 75% of post expiration. In level 3 it is 59% and level 1 is 75.43%. It is gradually decreasing when the GMFCS level is decreasing. Likely the peak expiratory flow is also decreases from 80% to 55% from level 1 to level 3 of GMFCS. Similarly, the expiratory reserve volume is also decreasing, but it is not significant. Difference was found. Similarly, the inspiratory reserve volume is almost similar in all the groups. And the vital capacity in level 1 is 73% of the predictive value and level 3 is 60% of the predictive value. And tidal volume, it is almost similar, statistically similar in all the levels. The chest expansion in level 1 is mean chest expansion is 2.93 centimeter in level 1 and 2.27 centimeter in level 3 of GMFCS. In all the assessment parameter except the force expirative volume upon in 1 second upon FVC, children with CP in the GMFCS level groups show lower value than the GMFCS 1 and 2. The GMFCS level third group show lower chest expansion compared to other two groups, but the post hoc analysis show statistically significant difference only between the GMFCS 3 and GMFCS 1. Force vital capacity, force expirative volume at 1 second of GMFCS third is significantly low compared to the GMFCS second and of GMFC second to the compared to the GMFCS 1. Peak expirative flow was significantly low in GMFCS third in comparison to the GMFCS 1 and 2, but no significant difference between the GMFCS 2 and 1. While vital capacity of GMFCS third group is significantly low compared to the GMFCS 1 and GMFCS 2, but no difference between the group 3 and 2. Our results show a significant difference in respiratory function and chest expansion in GMFCS level 3 group compared with the other two groups. The reason for this would be a difference in independent walking ability and low level of physical function activity. These results indicate that children with CP who walk with an assistive mobility device in most indoor settings have a poor lung capacities and respiratory muscle weakness. Decline of physical activity in pathological condition could lead to development of peripheral muscular abnormalities and dysfunction due to muscle weakness, increased muscle fatigue, reduced oxidative capacity, and dysfunction of coordination. Several previous studies reported a close association of respiratory function and muscle strength with amount of daily living activities or functional exercise capacity in children with neurological disease. Therefore, the present study's finding was supported by those of many previous studies. Our limitation of our studies, we acknowledge that our study has the limitation of small sample size. Further study will be needed for consideration of large sample size and other assessment parameters like total lung capacity, diffusion capacity, and respiratory muscles pressure. We concluding that it would be highly expected that the children with CP who walk with an assistive device in most indoor settings could have a poor respiratory function and chest mobility. Children with low GMFCS have a poor pulmonary function parameter. The take-home message is early assessment of pulmonary function should be considered, especially in low level of GMFCS children. Therefore, the intervention aimed at improving pulmonary function should be integrated in rehabilitation of these children who demonstrate poor physical activities, like the inspirative muscles strengthening, breathing exercises, and increases the physical activities. Thank you.
Thank you very much, Dr. Gupta. Very crisp message he has given and finished on
Thank you,
time.
sir.
Anybody has any question or a comment is most welcome.
I have one question for you. Like, you have included all the CP children, or you include only those CP children who have some pulmonary problems?
We take all the children, but at the time of enrollment there is no signs of pulmonary infection or other pulmonary problems like dyspnea or restlessness. Okay, thank you, sir.
Thank you very much, Dr. Gupta. May I now request Dr. Roy Chandra to please come on the dais from Kodikode Government Medical College.
Respected chairs, Yusing sir and Naveen sir, my teachers, seniors and friends. I am very proud to share a session with my Professor Srikana madam, my mentor. Namaskar madam. My studies on clinical outcome analysis of USG guided minimally invasive trigger finger release using a 18 gauge needle. This is a novel technique. 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 This is The trigger finger is otherwise known as stenosing flexor tenosynovitis, invented first described by Nota in 1850. That is, so it is also known as Nota's node. The prevalence is 2% in general population and 5% in type 1 diabetes, and it will increase to 10 to 36% in type 2 diabetic persons. Other etiologies are old age, metabolic syndrome, dyslipidemia, hypothyroidism, inflammatory arthritis, some occupation with high gripping activities, and post-CTS surgeries. Here is a pathology about the MCP joint. At the A1 pulley level, there will be tenosynovitis and thickening of this A1 pulley. The initial symptoms, finger or hand pain, finger stiffness. Later, there will be catching or popping when straightening the fingers, which is known as triggering. Fingers stuck in bend position, which is known as locking. And later, we may find locked and fixed fingers. The quinal graded into 5, grade 0, pain with flexion, no mechanical symptoms. Grade 1 with uneven motion during flexion. And grade 2, locking, which can be actively corrected. And grade 3 is locked digit, which can be passively corrected with the other hand. And grade 4 is a locked digit. Initially, in initial phase, it can be treated with anti-inflammatory medications. And steroid injections are very effective in stage 0 and 1. One injection is curative through the curation rate is 70 to 75%, and 2 injections is 80 to 85%, except in diabetic persons there can be recurrence. And surgery is indicated in stage 2 and above, can be open, percutaneous, or endoscopic. And open surgery, we need a theatre facility, we need instruments, there will be an wound which will be sutured, there is chances of scar tenderness, and longer duration of post-operative pain, and 2 to 3 weeks of healing time. That means 2 to 3 weeks of rest time also. And then there is chances of infection, especially in diabetic persons. For minimally invasives, there are special knives which are not, we didn't have it in Kozhikode. The equipment for our technique is lignocaine, Holtewell 5 cc syringe, 26 gauge 1.5 inch needle for giving local anesthesia, and 18 gauge 1.5 inch needle may be used as a knife. So this would be bent, the tip pointing up, so this can be used as a knife for cutting the A1 pulley. And this will be connected to the 5 cc syringe, so it can be as a handle for aiding easy manipulation. So the cost is almost nil. Out of the pocket expenditure of the patient is almost nil with this technique. And previously we were doing a blind procedure using a needle, which will cause incomplete release. The tip of the needle may rotate and may injure the tendon or the neurovascular bundle. So this is a dictum in surgery: never let the skin stand between you and the diagnosis and the treatment, but this machine will help you in seeing the internal organs without cutting. So the surgeons, our teachers, surgeons say, who learns anatomy from books should operate on books only. So we need adequate knowledge of the anatomy and the zonoanatomy. You know, the left, there is a normal tendon. You can see this is oval, and on the right you can see a person with a trigger finger, a round tendon, edematous with tenosynovitis. This is the longitudinal section. On the top it is a normal A1 pulley, and down it is a person with trigger finger with edematous tendon and thickened tenosynovitis and thickened A1 pulley. This is one of our patients. You can see this person is having grade 2 triggering. So this is our procedure. So the tip can be used under the USC guidance to cut the A1 pulley. You can see the results immediately, and there's a small needle prick wound only. This is the same patient. On the 3rd day there is no wound, and the hand is almost fully functioning. So this the study, the materials and method, we have done a one-group interventional study. Sample size is 63. Study is sitting in the Department of PMR, Government Medical College, Kozhikode. Study period is 6 months after ethical committee clearance. This is the inclusion criteria: age more than 18 in both genders, quinal type 2 to 4, patient not responding to conservative management, exclusion quinal type 1, uncontrolled diabetes, and local infections. So the two tools were used. One is a VAS and the second is the Quick-11. Now we got ethical committee clearance, the IRC clearance in January 2023. All patients were informed about the procedure and informed consent were also obtained. The procedure has already been described. So after the procedure, simple dressing will be given, which can be removed on the third day on review. So the person will be reviewed on third day for inspecting the wound site, if there is some infection or not. Activities can be resumed on the third day itself, and Q-dash and was measured before the procedure and at 1 week and 1 month post-procedure. So the result, 35% of our patients have type 2 diabetes, 24% have dyslipidemia, 6 have hypothyroidism, 2 have a history of CTS surgery on the same hand. The mean age is 52 years. 62% of the persons were females. As per Quinel's grading, 50% were having grade 2 triggering and 46% having grade 3, and 2 of the persons were having grade 4 triggering. The mean operative time was 7 minutes, ranges from 4.5 to 10 minutes. There is complete relief of symptoms with full range of motion in all. A mild pain after 6 hours, which is managed with acetaminophen or tramadol. Mean was only 3. 62 patients were able to start their hand activities after 48 hours. 1 developed mild CRPS, which has resulted in a week of treatment. This was pre-procedure was 6, which was reduced to 2 in a week and nil by 1 month. Q-score was 37 pre-procedure, reduced to 70 in 1 week and nil by month. So coming to the conclusion, the new technique of USC guided minimally invasive trigger finger release using a bent 18 gauge needle is very, very cheap, time saving procedure with quick recovery time and least complications, no need of a theatre facility, and surgical instruments can be performed in an OP room with musculoskeletal USC facility. The drawbacks were the no control groups. The thing is that after starting this procedure, we stopped open procedures and blind procedures, and the injection dipometrol steroid is used exclusively in grade 0 and 1, so there will be a bias if you compare it with steroids. So the follow-up period was also very short. So there is no competing interests. Acknowledgements to Sri Devi Menon, our professor, CG Sir, our guru in USC, Dr. Suraj, my friend Shahzad, our SR Lakshmi, and our patients. These are reference. In a new world, in a fast and furious world, the persons need to recover fast without much pain. So the conversations like this are very common nowadays. What are you talking about? Just lay eggs, and the hen says, no, I want an epidural. So see, we should never behave like an old crow by depending on the therapist. We should learn newer methods, simple intervention methods, simple things like this, and should behave like a modern crow. And thank you very much for the patient listening.
Thank you, Dr. Rai, for sticking time. Thank you very much. And questions? Any comments? We have time.
Pardon. Previous studies. Actually, we are following them for last 1 year. There is actually no recurrence. No recurrence at all. One complication was CRPS. One diabetic person developed CRPS that was managed with NSAIDs in 1 week. That's one complication. In diabetic persons only, sir. Others no antibiotic.
Compliance from the patient side.
It is good, sir. The excellent result. So we got more patients due to their. The news was spread from one to other, and we have now more patients with trigger finger from other departments also, even from ortho.
Can it be done in outpatient procedure?
Yes, sir. Outpatient procedure. We'll give the patient for half an hour observation after procedure and we'll send.
Thank you.
None, sir. None in this 63 patient, all the full recovery.
Okay. Because I had done same study 11 years before, which was published in PubMed also, and the technique of hand and upper extremity surgery.
Which
In
needle,
that-
sir? We have used now 18 gauge needle, which is
I had used
more
20
stiff.
gauge because
yes, yes. 18 is more stiff. We have tried 20 and
18
21.
is much bigger, cause
Yes.
more trauma. So I had used 20 gauge.
But this is more
And
effective, sir.
In that case, I had one failed case in which the cause of trigger finger was trauma. Okay. It developed after trauma. He fell down, and that case was failed. All the cases were successful.
Okay, sir.
One more question. Whom should we not do this surgery on? Can you tell me in which?
Uncontrolled diabetes and probably trigger finger secondary to the inflammatory arthritis. Probably there can be a chance of fracture.
Okay, remaining discussion, I think we can do one to one.
Even you can avoid in trauma cases
Yeah,
also.
please. No discussion between. Yeah, please. Thank you.
Thanks.
Thank you. And we, as chairpersons, we thank all the speakers for sticking to time and making the work of organizing team easier. And we also thank the organizer to give us this opportunity.
Thank you very much. We really had a very interesting topic and we made up some time. Thanks to everybody. Thank you.
We'd like to call the speakers to honor. Dr. Tyagarajan, I request the chairpersons to honor the speakers. Tyagarajan, sir. Dr. Shrikala, madam. Dr. Siddharth Rai. Dr. Amit Kumar Malik. Amit. Dr. Ravinder Singh. Dr. Sandeep Kumar Gupta. Sandeep Kumar Gupta. Dr. Rai R. Chandran. I request Dr. Uday Singh to honor the chairpersons. 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 next is the scientific session number 5. Call upon chairpersons Dr. Ramesh and Dr. Ravi Shankaran on stage, please.
So we'll start scientific session number 5. This is the last session for the day. We'll have our first speaker, Dr. Shahadad, the professor from Government Medical College, Kozhikode, come up and talk about neuromuscular ultrasound applications in PMR. Dr. Shahadad.
Respected chairpersons, respected teachers, and my dear friends. So the topic of discussion is neuromuscular ultrasound from a physiatrist perspective. So neuromuscular ultrasound means you are using ultrasound for actually evaluating, diagnosing or evaluating neurological and neuromuscular conditions. That's the purpose of neuromuscular ultrasound. So as physiatrists, we have got certain advantages, like we can see the muscles and the nerves. By ultrasound, we are able to see the muscles and the nerve, and we are also able to see their electrophysiological activities by doing nerve conduction studies or EMG. And we are able to manage them by giving exercise or by giving neurorehabilitation. So physiatrist has got a certain advantage when it comes to neuromuscular ultrasound. There are many benefits or advantages of ultrasound over MRI. One thing is that actually when you are doing the ultrasound, you can easily move the probe along the course of nerve or muscle continuously, and you can do a dynamic evaluation easily. That's not possible with MRI. But there are many factors when you are doing a neuromuscular ultrasound. There are machine dependent factors, patient factors, and most importantly the expertise of the examiner. So that is the way you see a nerve in short axis view and the long axis view. You can see the epineurium as a bright line and the perineurium as these white lines inside, and this you characteristically call as a honeycomb appearance. These are the usual abnormalities that you find with nerves. And why are you getting swollen nerves? When you have got compression in a nerve, proximal to that compression you have abnormalities of permeability of vessels and you get edema. And the second thing is that when there are certain lesions of the nerve, there can be demyelination and remyelination, or there can be onion bulb phenomenon. All these things will cause swelling of nerve. So a swollen nerve is the usual finding that you are getting, an abnormal finding that you are getting when you are imaging a nerve. So when it comes to focal neuropathies, probably focal neuropathies are the most common thing that you use an ultrasound for evaluation. When it comes, you have to have certain values normal values of cross-sectional areas of various nerves at various positions, and that actually varies in between populations. And we do have and we are now developing a normal values for our own lab. Usually the most common in neuromuscular ultrasound that is performed by physiatrists is that for carpal tunnel syndrome. You can have many parameters. The most important or the most commonly used is the cross-sectional area at different levels. You are having other many types of dynamic evaluation and different diameters of nerves at different positions. All these things you can do for a CTS. So you can see this CSA and this CSA, and you can see this one that is probably somewhere around 20 millimeters square, and you can see this in a longitudinal view. That is how you see a nerve in carpal tunnel syndrome. Then there is a flattening ratio and there is a bowing, but these are usually not so commonly performed. But for research purpose or for academic interest, or if you want to have a very accurate evaluation, you can go for all these calculations. And this is the sublimis ridge, and you can see the median nerve coming down. And entrapment, so proximal median entrapment is not a common entity, even though theoretically you have the pronator teres syndrome, you have the aponeurosis, compression, all these things, lacertus fibrosis, but this is also a rare cause. But you can see that this is actually the swollen median nerve, long axis view and the short axis view, that is actually compressed by the flexor sublimis or digitorum superficialis ridge. And often you see many anatomical variants, like a bifid nerve, okay, or this is a big bifid nerve. Then this is one study published by our center. Then again you can see the difference in size and the corresponding NCS. Radial nerve, like a schwannoma in the SRN, ganglion of the peroneal nerve. Okay, then CIDP and AIDP, you have, there is difference in size, but these are not very specific. AIDP also you can get a difference in cross-sectional area, but this is not very specific. CMT1 and 2, there also you have this increase in size, but again it's not very specific. You cannot differentiate these conditions. Then liabilities to pressure palsies, probably you can screen the nerves which are actually prone for this pressure palsies. Diabetic neuropathy, the studies have not found a very good correlation which can be used clinically. And this was one study done by our center. This also came to the same conclusion. Vasculitic neuropathy, it's an experimental stage. Okay. Leprosy, there is again CSA increase, and the color Doppler increase may be seen in lepra, but not so common. Again, one study published from our center. Brachial plexus, you can actually have a swollen brachial plexus trunk, usually in trauma. And then coming to the muscle, probably this is the first study by Heckmat. And you can see that you can see the muscles, normal muscle, and then when you have this infiltration, you get a hyperechoic shadow over here. Okay, so this is a normal pennation, and here you can see the technical issues. When the probe or the ultrasound wave is perpendicular, then you see the fascia clearly. But here there is a fascia, but that cannot be clearly seen because that is almost parallel, in line with the wave. And here, because if you tilt the probe slightly, your echogenicity changes. So you may think that this is slightly hyperechoic, but no, this is because of this is slightly hypoechoic. This is because of the probe position. So you must be very much aware of the technical issues. Okay, here this is because of the time gain TGC, time gain compensation, that is set at a different level. You see this is hyperechoic. Or because of the compression, you can see the skin that is flattened over here, and you see the muscle size is less. Okay, you can quantify the echogenicity, or simply you can see the Heckmat grade, where you can actually roughly quantify the echogenicity 1, 2, 3, 4, and you can actually select the muscles depending on the echogenicity for biopsy and all. And dynamic US, you can see the fasciculation and which very good machines, you can even be able to see the fibrillations. These are the fasciculation, the adductor pollicis, a deep muscle. And this is in ALS, where you are actually comparing the size of the muscle and echogenicity. This is the normal, and this is the ALS affected muscles. And diaphragm thickness, that is also, you can do the thickness. This is the inspiration and expiration thickness of the diaphragm. That also you can do, especially in ALS. And SMA also, you have different types of the increased skin thickness and different types of damaged and non-damaged muscle areas. And this is different types of muscular dystrophies, LGMD, DMD, various muscles. This is the gastrosoleus, you can clearly identify the difference. And infectious myositis, where you have increased vascular signals. This is a chronic radiculopathy, you can see the texture of the muscle, the echogenicity has changed. And electrodiagnosis, you can use it for entrapment. And diaphragm EMG also, you can use the ultrasound. This is one study we are doing now, that is in the diaphragm thickness in SCI. And for difficult areas like near the lung and all, you can see the, for EMG you can use the ultrasound. Then for ICU induced weakness, many ultrasound parameters are being tested. Some of them are useful, but they are still in a testing stage. And spasticity, you can look for these parameters, fascicle length, pennation angle, and even elastography. And this is our study which will be presented tomorrow. And botulinum neurotoxin, you can actually find out the muscle. Probably this is the one thing that's very useful. You can clearly see that when you select a muscle for botulinum neurotoxin injection, I will not select this muscle, but I will go for this muscle. And for this muscle, I am not going to give Botox because I know that it won't be that much effective looking at the echo texture of this muscle. And the future direction is actually artificial intelligence. You can use machine learning and deep learning for assessment of the neuromuscular ultrasound. That is important because the technical issues is very much important when you are actually assessing a muscle. The echogenicity and the thickness, everything can vary depending on the machine setting and depending on your experience. So AI may be a very good tool to help us to have neuromuscular ultrasound being performed in a better way. Okay, thank you very much.
Good presentation, sir. Excellent. Very well delineate the anatomical anomalies like bifid things, and it will be very good. I mean, very well correlate with the other gold standard methods of evaluation in a peripheral nerve entrapment in nerve enteropathies. Any question, please? Any question?
Sir, how often do you use shear wave elastography in your practice?
No, our machine is not having the elastography. I don't use that.
No more question. Thank you very much, sir.
Thank you.
Next, may I request Dr. Swigil, Assistant Professor, K.S. Hegde Medical College, Mangalore, to please present his paper, Evidence-Based DVT Prophylaxis. Please, sir.
Good evening, everyone. Thank you to chairs for giving this opportunity, and a big thank you to all the audience for still being here. I thought it would be between us because it's a long day for all of you. everyone is being here since 8 o'clock in the morning. So thank you very much for being here. My topic for today is evidence-based DVT prophylaxis. And what I'm going to mainly highlight is how important is it for us in our scenario to still give prophylaxis for DVT. So I may divide my talk into introduction, the need of prophylaxis, role of a physiatrist, the options, and the conclusion. So as we all know, DVT is a medical condition that occurs when a blood clot happens in a deep vein. Venous thrombosis usually develops in lower leg. It can be thigh or pelvis, but rarely it can happen in upper limb also. It can happen as early as 72 hours post-surgery or post the event, but as the time passes, the incidence reduces. Now, need of prophylaxis, is it needed? So we have studies mostly from West where the incidence is quite high, and it is emphasized that everybody who has the risk factor, which we see from either Virtue's triad or Wells criteria, if you have the risk factor, better to give prophylaxis because the incidence is quite high. But in Asian population, it is still considered as not at par at West. But of course, we have multiple studies. The newer studies which are coming out are one side it's telling that there are comparable incidences in Asian countries as well as in West, whereas most other studies, they are finding out that the incidence is low. And some of the reasons which have been highlighted are that in Asian population there are high fibrinolytic activity, the lifestyle, lack of activated protein C resistance, low intake of fat, lower incidence of obesity, higher incidence of blood group O, climatic conditions. Different things are postulated, but one important thing which have been highlighted in the studies is that we don't have many comprehensive studies in Asian population, especially when we talk about neurological conditions like spinal injury. But now, in current times, we are coming up with good studies, and they are coming up with nice results about the incidence. But still, most studies are finding out that incidence in Asian nations are still less. So what has been postulated and suggested by different studies is that we should try and find out the incidence in our region, and on the basis of that we can come up with the prophylactic regimen in our area. And moreover, we have to also consider that what kind of population are we dealing with, because one side, if we start chemoprophylaxis, then if there is a lack of follow-up and poor availability of lab facilities, monitoring of INR and APTT becomes difficult, especially if they are on agents like warfarin. And if we start them on, costlier agents like factor Xa inhibitors, then there is chance of bleeding and there is no facilities for checking, as well as cost. Sometimes the cost is even more than their monthly income. So the adherence becomes a question. Now, what is the role of physiatrist? Having said all that, let us see how a physiatrist is important when it comes to DVT prophylaxis, especially in neurological injuries where patients have either, where they are on bed-bound condition. So there is a considerable evidence that in neurological conditions, the physiology becomes a little different, as there is interruption of neurological impulses, and the ensuing paralysis cause profound metabolic changes in blood vessels accountable for venous thrombosis. Altered venous competence with complete spinal injury manifest by a decrease in venous distensibility and capacity and an increase in venous flow resistance. Vascular adaptations to inactivity and muscle atrophy rather than the effect of non-working leg muscle pump, and sympathetic denervation cause thrombosis. So this is being highlighted in these studies, which comes to, or which infers that thrombosis established through venous incompetence cannot be reversed by anticoagulation alone. So that's where the role of physiatrists comes in. Measures to increase venous distensibility and decrease flow resistance are also required and can be provided by exercise or intermittent pneumatic compression. So studies suggest that measures to increase venous distensibility and decrease blood flow, of course, I think it's the same thing. So this is important, that just in conditions where we have, something like spinal injury, where even autonomic system is involved, just anticoagulation, just chemoprophylaxis may not be enough. And that's where the role of physiatrists come in, where we need to use multimodal approach along with or plus minus chemoprophylaxis, but definitely a role of exercises, mechanical prophylaxis, and early mobilization should take up the upper hand. So the options which are available for chemoprophylaxis are unfractionated heparin, low molecular weight heparin, warfarin, or direct oral anticoagulants like factor Xa inhibitors. And mechanical prophylaxis involves early mobilization, exercises, intermittent pneumatic compression, and elastic stockings and compression bandaging. Now, if we go by evidence, none of it is considered to be effective alone. And among the mechanical prophylaxis, intermittent pneumatic compression is considered to be superior than other modalities. But most of the studies say early mobilization can reduce the risk of DVT to much higher extent. Even in ICU, patients can be mobilized in different ways depending on their conditions. So mechanical methods of DVT prevention are effective as compared to no prophylaxis, but better results are obtained when used in adjunct with pharmacological prophylaxis. This is some of the studies come up to this conclusion. So combined method are superior as compared to use of either one. So now we have only chemoprophylaxis, which is generally followed. We have mechanical prophylaxis, and we have combined methods, and physiatrists have an edge because they can use both of them as per the requirement, the condition of the patient, so that the risk also can be reduced, and they can, and it's not a burden also for the patients. So I want to conclude telling that mechanical methods are effective. It's important that we see the patients and do a simple study in our center as if possible, and see what's the incidence around us, because the climatic conditions, the food habits, the sedentary lifestyle also affects. And at the same time, as we saw, that neurological conditions like spinal injury, just chemoprophylaxis is not enough, because if we see in one way, the mechanical prophylaxis also has, if not more, equally important role in preventing DVT. So we had a study done during my PG where I saw around 300 patients of spinal injury who were admitted in last 16 years. I tried to find out how many of them developed. Of course, I was doing a chart review, and I found the incidence of 4%. It means just 13 patients out of 300 were there who developed, and just 2 of them have developed pulmonary embolism, and 1 of them died. Now, there was a limitation there that I was just doing a chart review, and we were not able to find out asymptomatic DVTs because every person was not screened. But at the same time, the incidence was found low, at least the people who become symptomatic. So the take-home message that I would say is, instead of directly jumping to chemoprophylaxis, it's better that we just have a small incidence study in our center and then decide on chemoprophylaxis, and at the same time choose as per the requirement, the condition of the patient, and then the choice of prophylaxis depends on that. And the last is early mobilization is the key. Thank you very much for your patience.
Nice talk. Any questions?
Yeah, one quick question. As soon as DVT is diagnosed, now recent publications on early mobilization as soon as you start on warfarin after diagnosing. So what are your comments on that? How early you do suggest? Starting to mobilization.
Yeah.
The senior consultant in cardiac anesthesia and
okay. So now if we say mobilization after DVT, now it also depends on the site of it. Let's say if it's a distal DVT, for example, if it's a calf veins, the risk of dislodgement is considered as quite less. Even there are studies who are still debating whether a distal DVT should receive a treatment also or not. But whenever it comes to proximal DVT, we have to make sure that general movements and activity or daily living, there is no problem. But when it comes to exercises, we have to be careful where that muscle should not be, should not be stretched much, so that there is less chance of dislodgement and embolization of the DVT. I hope that answers.
Any other questions? Dr. Chad, I have two questions for you.
Yes, sir.
So one, in PMR, we frequently train people with brain injuries, right? Unconscious patients who are waking up. And in that post-recovery phase, as they regain consciousness, they're under a lot of stress. They develop upper GI bleeds. Do you anticoagulate those people or not? So people with brain injuries, as they recover consciousness, will develop upper GI stress bleeds. Do you use DVT prophylaxis in those patients? They're bedbound, they're not walking. Do you use anticoagulation in them, yes or no?
Personally, I don't have much experience of such patients. My particular study was on spinal injury. And most of the guidelines which has also come are either from orthopedicians or hematological societies. So I will not be able to give a right answer to that. Maybe
One more. In spinal cord injury patients, they're not going to, if they're complete, they may never walk again. Do they have lifelong anticoagulation, or do you stop it when they go home?
I would say as soon as they are, nowadays what I am seeing in my hospital, the orthopedicians, because now the surgical techniques have improved, they allow mobilization on POD1. In fact, POD0. As soon as the patient is shifted in the morning, evening, they start making him sit. So in that cases, I don't think it needs to be, because if we have a rehab department associated, mobilization can start early. I don't think there is a need. And they generally do not follow that, and we don't see much. I have seen only one case of DVT in last 5 years from the same department when I see the patients coming.
Thank you. Nice talk.
I request all the delegates who are in the stall premises and refreshment areas to come inside the auditorium. We are having a presentation regarding critical care rehabilitation as a continuation of yesterday's workshop by Dr. A.J. Rajendran sir. Request all of you to assemble in the auditorium.
Now I request the chairpersons to honor the speakers. Dr. Shardat, please come to the dais to receive the honor. Dr. Shahadat, please come to the dais. Dr. Shushil. Thank you, sir. Now I request Dr. T.J. Renganathan, sir, to facilitate the chairpersons. Thank you, sir. Thank you all. We are concluding today's scientific session and of day 1. And today we are having a dinner at PSG auditorium here itself by 7:30. I request all of you to join for the dinner. Thank you.